Why am I not seeing? Hello, you guys. Hello, Facebook. Hello, YouTube. It's nice to see you today. Jill Osborne, president of the Interstitial Cystitis Network, ready to start a new support group meeting today. Yes, today. That said, to try to figure some stuff out here. Hello, Cindy. Hi, Shannon. I would love it if I could pop out my chat so I didn't have to turn my head. Hello, Angel. How are you? Nice to see you. All right. Is that okay? Is that okay? Is that okay? Okay. Listen, I'm an ICer. I never thought that I would have to be a tech guru trying to set all these things up, but I do. Hello, Cindy. Hello, Shannon. Hi, Lucinda. Hello, Anne. Anne says, Dr. Hasmi says, I have IC and Vulvodynia without testing, gave me a script for physical therapy. I support that. I absolutely support that. Now, we've got, our theme today, guys. Hello, our new book, IC 101. It's not just a bladder disease. Look at this. So if you've wondered why I haven't been doing as many support group meetings, it's because we're trying to finish this baby. 2 years. It's a 2-year project. And I partnered with Gay Sandler and Andrew Sandler. What we did is we started at the template with their last book, The Proactive Patient Managing IC and Related Conditions, which was published about 7 or 8 years ago. Completely updated it. Added new chapters, added new content, and hi, Donna. I'm so excited. Oh my God, if we could have had this 25 years ago when I was diagnosed, it would have changed my life, So our official title is IC 101 because I want you to look at this as a course. This is about taking a class. We are long past the days of thinking that IC is an incurable bladder disease. Long past that day. Today, we think of IC as a pelvic pain syndrome. Why? Because other structures in the pelvis are involved. So getting back to Anne here. So Anne has got IC and vulvodynia. So we're going to be looking at 2 fundamental things for her. Number 1, pelvic floor tension. Because if her muscles are tight, that's compromising blood flow to the bladder. It's compromising blood flow to the vulva, and it's potentially compromising nerve conduction. Nerve functionality, because nerves need good blood flow. So we know that for some patients, pelvic floor physical therapy will resolve the symptoms of vulvodynia. It can resolve the symptoms that you think are your bladder, frequency, urgency, pressure, pain. But guess what? Your symptoms began, actually, some of you, because of a muscle injury. It's called a somatovisceral reflex. So we've come a long way today. And this book now is the update. And guess what your freebie is today? I got a whole case of them right here next to my desk. I'm so excited. We did it in a spiral format because I want you to be able to open it up. I want you to be able to mark it up. And you can see here from Gay, because she works with, she has a history of working with physical therapy. There's going to be a lot of pictures for you to go through as you're working with your pelvic floor and more. But here's the thing. Again, IC 101, it's not just a bladder disease. That's what you got to get through your consciousness here, especially for you grizzled veterans who you've had symptoms for 20 years, 25 years, 30 years. You have been doing bladder therapies for eons and you've never gotten better, or you've never been cured, or you've never been healed, or you're getting worse rather than better. It is time to stop and take a step back and revisit the diagnosis. And Donna, you should have it on Monday. You should have it tomorrow because I've already sent you one. Because I really want to hear your feedback. I'm going to be sending a lot of these out to you guys. All right. So why is this so important? Why is this so incredibly important? Hi, Barbara. If you didn't see my blog this week, it was fascinating. Imagine living for years with the worst form of IC, Hunner's lesions. Hunner's lesions. You've tried everything. Nothing's worked for you. But you also have a prolapse. Pretty bad prolapse. A prolapse so bad that you decide that you need to have it surgically repaired. So, and it's hard. You want to have surgery down there? That's a scary prospect. I know. I had to have a hysterectomy. Let me tell you, I wasn't concerned about the cancer. I was concerned about setting my IC back 20 years. I mean, I'm being brutally honest here. That's exactly how I felt. So here, published in the International Urology Journal, is the story of a 73-year-old woman with severe Hunner's lesions. She's got urgency. She's got nocturia. She's got frequency. She has a prolapse so severe, she's got to have a surgical repair. And guess what happened? She was healed. So they lift her, they repair a ligament that's been damaged. They repair the prolapse. And when they repair the prolapse, her Hunner's lesions healed. She's cured. She's cured. The doctors share her story in this case study that was released on May 21st. So this is so interesting. Here's something you've never heard about before. It's called Posterior Fornax syndrome. How freaky is that? Posterior, meaning the backside of you. Fornix. A fornix is like a pocket. Syndrome. And back in 1938, they learned that if you have a specific damaged ligament, it's called, let's see, what is the name of the ligament? I have it in here somewhere. But anyway, USL. If you have laxity or injury to the USL ligament, that it can cause chronic pelvic pain and bladder symptoms. It was published in 1938 and in 1993. How the hell can raising a ligament, restoring a ligament, resolving a prolapse fix a Hunner's lesion? Isn't that the question? She is undeniably cured. So how does this ligament get damaged? This ligament gets damaged through pregnancy or trauma. Basically what happens is that the vagina starts to twist. So if your vagina normally faces this way, if you have a damage to this ligament or this ligament is torn, it can twist like this. It's stunning. It's very, very interesting. So how do we know if you have this ligament damage? All they do is they insert a little speculum up by your cervix and they lift where the ligament normally holds that tissue up. And if inserting this little, God, what's the right word? I mean, what is the right word for it? What did they call it? Oh, speculum. Okay. If they can use a speculum and lift where this ligament normally provides structure and your symptoms go away, guess what? You might not have IC. You have something called posterior Fornix syndrome. It's fascinating. So the authors, if you read my blog, this is over on our website, the IC Network website, I summarize it. I give a link to the study and I say the authors raise an important question. Are patients being screened for this condition, which when identified correctly is curable? Fascinating, and yet again reminds us all that bladder symptoms aren't always the result of a bladder disease. A simple diagnostic swab could reduce the suffering of many. Further research is clearly needed, particularly in trying to understand how and why a lesion could form in this circumstance. Now, remember, too, we had a paper that was published, a larger study that was published last summer, which showed that 70% of men with testicular pain had an underlying hip abnormality. We had in 2008 a federally funded multi-center study for IC, which showed that pelvic floor muscle therapy outperformed bladder therapy. This is why we are in a whole new era in IC. We are in a whole new era in IC. This is about looking beyond the bladder. It is so incredibly important that you pause and take a step back, realize the information that you got 10 years, 20 years, 30 years, 40 years ago is now wrong. Yeah, do some of you possibly have estrogen atrophy in your bladder? Sure, certainly. Could some of you have chronic infection in your bladder, especially fungal infection? Sure. But the bladder does not function in isolation in the pelvis. Western medicine fails the pelvic pain patient simply because it doesn't look at relationships. Remember, doctors stay in their sandbox. Urologists like to stay in the urinary tract. Gynecologists like to stay in the reproductive tract. Gastroenterologists stay in the bowel. And here's the deal about the pelvis. It's a small confined category where there's a lot of crap going on in here. It is full of structures. And they do not operate in isolation. So we have the urinary tract in the pelvis, we got the bowel in the pelvis, we've got the reproductive tract in the pelvis, we've got a hell of a lot of skeletal muscles in the pelvis, we've got giant blood vessels in the pelvis that go down both legs, and we've got important nerves that go through this structure, go through this pelvis to support the legs. They do not operate in isolation. They influence each other. How do we know that? We know that, number one, through something called the viscerosomatic reflex. Visceral means viscera, means organ. Somatic means muscle. Okay, so question number one is, can an organ change muscle behavior? And the answer is yeah, absolutely. Because when you're in pain, let's say you're holding your urine, you're on a long car ride, and the driver doesn't want to pull over, and you got a lot of urine in there and it's starting to hurt. Your muscles are going to get tight to protect you. That's called the guarding reflex. So we know organs can change muscle behavior. Anytime you're in pain, your muscles are going to get tight. That's the way it works. But question number two is, can muscles change organ behavior? And the answer is absolutely, muscles can change organ behavior, because if your muscles are locked down and tight, so again, think of this as actually a pretty good representation of the pelvic floor, right? The pelvic floor is a three-sided box that's kind of open in the front. So you've got muscles along the bottom, and you've got muscles along the side and along the back, right? And normally the pelvic floor muscles are flat and comfortable along the bone. But when they get tight, what happens? They lift up and they push down. They can crunch down like that. Mine is, I've got these stupid ruptured discs in my back, and my right pelvic floor is not happy. And so these muscles get tight. And as they get tight, what do? They limit blood flow. They limit nerve function, because nerves need oxygen to function correctly. They need blood supply to function correctly. And if they don't have good blood supply, the nerves get dysfunctional. And that dysfunctional nerve can then spread. It can, through something called neurocrosstalk, it can start influencing other nerves in the pelvis. It's just so interesting. We've learned so many good things. So anyway, this is my attempt at trying to get more of you to look beyond the bladder. If you are still struggling, if you just don't get it, if you're older and the doctor has said, hey, your skin is dry, and you try estrogen once and it burns like hell and you never do it again, this is going to explain why that's a terrible mistake. So I'm super, super, super excited. So this is currently available on our website and our store. There's a print. This one is $24.95. It's almost 2 pounds, 160 pages, full size. And then the PDF version is $9.99. I'm going to have a Kindle version and an audiobook version in the next month or so. So anyway, this is going to be our freebie. So as the meeting goes on, we will be giving them away. So anyway, let me introduce myself. I'm Jill Osborne. I'm the president and founder of the Interstitial Cystitis Network. I'm the longest serving IC support group leader in the United States. And at this point in time, probably in the world, although Germany might have a group that's older than mine. I'm not sure. I bring to you 3 college degrees, a degree in chemistry, a degree in pharmacology, drug development, and a degree in psychology. My purpose in doing these meetings is to make you so strong, so knowledgeable, so informed that no one can mess with you again. I don't want anybody to tell you it is all in your head. I don't want anybody to tell you, oh, you're just sensitive, get over it. Oh, it's all in your head, honey. It's not real. We can prove the sensitivity now with a very, very simple skin biopsy. So lots and lots, again, of very, very good things are happening. Now, normally when I do these meetings, the first 30 minutes, I do some sort of mini lecture. I don't really have one prepared today other than to talk about this book. I might read the introduction in this book. And then obviously we're going to take your questions. We are simulcasting live on Facebook and YouTube on 2 separate internet streams. So if I'm looking up there, I'm looking at Facebook. If I'm looking here, I'm looking at YouTube. So what I want you to do is feel free to ask whatever questions you want. If I don't answer it right away, ask it again. Man, you got to be the squeaky wheel here because it scrolls by really, really quickly. I'm sorry, but it does. So let's go over to Facebook here. Hello, Shannon. Happy Sunday to you too. Hello, Lucinda. Hello, Ann. And straight out of Blue Ridge, Georgia. Hello, Georgia. Shannon, still pain-free. I'm on a 6-month roll. Girl, congratulations. I'm so happy for you. Cindy says, those earrings, yeah, aren't these cool? I like these earrings. From Holly Yashi, which is a women-owned California business. Hello, Danielle, who says ciao. Nice to see you. Hello, Ruth. Ruth says she's been able to eat everything lately. Awesome. Hello, Gemma. Hi, Sylvia. Hi, Cindy. Hello, Jill. Jill says, always nice to meet another Jill. Always nice. I've been watching you for a while now and learning so much. Thank you. Awesome. Oh, hold on. My computer's all moving around. Belinda says, let's see. Belinda says, hello, I tried the NAN product. Unfortunately, made me sick due to kidney disease. Belinda, which one did you try? There are lots of different NAN products. She's talking about Natural Approach Nutrition. Natural Approach Nutrition is the up-and-coming supplement company that's really created some very, very, very good formulas for people with lower urinary tract issues. Anne says, started alkaline water about 3 months ago. It has helped with my symptoms. So, Anne, I got to tell you, I'm not a fan of alkaline water. I remember I was at, because we have a shop for IC patients, and I'm always looking for food. I would go to food shows, and I was always looking for low acid food. That's how we found Colorado Mountain Jams and Jellies, which is a true low acid jam or jelly that we sell. And so one of them they were giving away alkaline water. And I drank a sample and it stripped all the mucus out of my mouth. It was terrible. It's absolutely terrible. And I thought, oh my God, if that's going to do this to my mouth, what is it going to do to my bladder? The last thing I want to do is strip the mucus off my bladder, right? That would be terrible. So here's my approach with alkaline water. And that is, I don't think you should do it every day. I think that's a mistake. One of my old chemistry teachers back at Santa Rosa Junior College many, many years ago, as he was giving us our safety lesson in organic chemistry and inorganic chemistry, he explained why you have to be so careful with acid, right? Like sulfuric acid. Obviously, if you put sulfuric acid on your skin or you spill in your eye, whatever, you're going to have a problem. It's going to burn it. But bleach will do exactly the same thing. And bleach is not acidic. Bleach is alkaline. And so if you've ever spilled bleach on your hands, it gets really, really slippery, right? And that's because the bleach is literally basically kind of dissolving your skin. And so my approach with the bladder is to be pH neutral. The last thing I want to do is throw a lot of acid in my bladder or alkalinity in my bladder. Now, of course, you guys, you got to remember, I'm not a doctor. I can't give you medical advice. My job here is to educate you, poke you, give you a few pokes in here and there, give you a few ideas to explore. Um, but I do think doing alkaline water every day, all day is a mistake because you're running the potential of irritating your bladder in the opposite way that acid would. But if you wanted to do one a day, following up with water, it is what it is. But I personally do not believe in doing alkaline water all day, every day, only drinking alkaline water. I think that that's a mistake. The human body maintains acid levels and alkalinity levels to a minute degree in the bloodstream. And there's nothing you can take that's going to change that it is the human body's job to maintain acid level or alkalinity levels. So it's not like more is better. All you're doing potentially is changing the pH in your urine. But again, you can go too far and you can end up giving your bladder the equivalent of a chemical burn from alkalinity as compared to a chemical burn from acidity. Hello, Julianne. Hi, Stacy. 25 years ago, I was told I had IC or endometriosis. The doc followed with hope it's endo because at least they can take out the uterus. Isn't that the truth? Suzanne. Hello, Suzanne. Hi, Julie. Gemma says, IC is the worst. It's ruining my life. Well, Gemma, we got to figure out what the cause is, right? It's not just the symptom. The symptom is frequency, urgency, pressure, pain. Now we got to figure out what is causing that symptom. Yvonne says, just able to join again, been a while, just had a scare like you have endometrial cancer. See the doctor next Friday. Initial report looks okay. Yvonne, honey, good luck to you. I'm really going to say a good prayer your way because I know exactly how you're feeling. Shannon says, how's your mom and dad? They're doing pretty good right now. Hey, my mom, we had very, very good. You guys, for those of you who don't know, I care for my 98-year-old dad and my 92-year-old mom. You hear them every now and then they walk through. It is a beast of a job, and we're starting fire season, and we're already having power outages. It's like, oh my God! Last night I was going, I don't want to do this again. I don't want to go through fire season again. But miraculously, they're both doing pretty well. My mom is no longer anemic. She doesn't have to have her infusions. Yes, so happy about that. Now the challenge is just getting them to eat and drink, and getting enough fiber. It's all about drinking, eating, and pooping in my house right now. Galen says, I want to look into my ligaments and muscles in my hip when my bladder is full. Everything in my pelvic region hurts until you empty your bladder. Yeah, I mean, it's just absolutely fascinating here. Hi, Pamela. Pamela says, so glad you finally caught you live. Lucinda said, I wish I could find a urologist who had any of this information. Lucinda, it starts with the book. Get the book. Get 2 books. Give one to your doctor. Hannah, and guys, if you have a receptive doctor, a doctor who says, yeah, I'd love to have more information, and you give me their information, I will probably just send them a book, no charge, just so they have it. Hannah says, have I heard of Dr. Brian Evans at Wake Forest? No, I have not. Hi, Nancy. Nice to see you. Loretta says, how does this book jive with Jerome Weiss's book? It's completely supportive, and I talk about Jerome Weiss's book in several places in this book. I mean, this is kind of a summary. For more detailed information, I'm referring you to the places where you need to go. Let's come on over to YouTube here. Hello, YouTube. Angel says, I have the IC diet, but everything I eat cramps up in my stomach. So, Angel, we did a survey of IC patients years ago. I'm going to say 6, 7, 8 years ago. And the survey really asked patients what type of stomach issues did they have? Because if you look at all the old studies, they asked patients if they had irritable bowel, but none of them really asked about stomach disorders. And I, for one, had had several bouts of gastritis, um, and ended up in the hospital with gastroparesis, also known as delayed stomach emptying. And so if you're eating food and it's like sitting in your stomach and you're starting to belch, that's a symptom of gastroparesis. It's the strangest thing where food will literally sit in your stomach for hours. Like I had my endoscopy at 4 in the afternoon and my breakfast of scrambled eggs was still in my stomach. It literally was not, the food was moving very, very slowly. And the longer that food sits in your stomach, it starts to ferment, especially if it's a carb. If you've ever made yeast bread and you put yeast in warm water and sugar, what does it do? It starts to bubble. Well, that's kind of what happens in the stomach during gastroparesis. The food starts to ferment. And so, Angel, the real question here is, are you belching a lot? If you're belching a lot, you could have gastroparesis. And it turned out that 90% of the IC patients who responded to our survey reported that they had stomach issues, and they had a variety of issues. Quite a few had GERD, gastritis, gastroparesis, and then there was one other one. I don't remember what that other one was. So if it is gastroparesis and you do find that you're belching a lot, I got to the point where mine was so severe. I mean, I remember when it started, like I was working out at the gym I used to belong to, and all of a sudden I just started belching and it hurt. It got so bad over that 3-month period that I lost like 30 pounds. I just stopped eating. I looked like a skeleton. It was really bad. And I couldn't even drink water. And that's how I ended up in the hospital. And what I learned about that is that it's about eating the right foods in small quantities to help the nerves recover. And that's when I closed my office of the IC network, which I had a very nice office down about 5 miles away, because I couldn't do that at work. I had to come home so that I could make little tiny meals. And really, for about 9 months, I ate like little bites throughout the day. Turkey, sliced turkey or just little bits of this and that. But the other thing with gastroparesis is you want to avoid foods that are hard to digest. And that was the pivotal moment for me, is that when I stopped eating leafy green vegetables, I was 80 to 85% better. And that's the same with IBS. And we also have the connection now, right? And we've talked about that in past meetings. IC subtype 5, central sensitization, chronic overlapping pain conditions. For those of us who have IC, IBS, Vulvodynia, we have TMJ, all those things together. And it's really characterized by extremely sensitive skin, which I have, extremely sensitive skin, and a very wicked sense of smell, with a few other things like that. And we know that that's about the central nervous system, that the central nervous system has become maladaptive. The central nervous system isn't functioning as correctly as it should be. And we also know that the smallest fibers in the skin, we call this small fiber neuropathy, are often involved, and that's what drives that skin sensitivity. So not only do we have small fibers in our skin, but we also have small fibers in our stomach and in our bladder and in our bowel. And so thus would explain why certain foods can be a bit more irritating for those of us, or caffeine, things like that. So we're connecting the dots. We're connecting the dots here. Now we are understanding cause and effect. Now we're understanding why some IC patients get this, and then they get this, and then they get this, and then they get this, whereas others just only have one thing and it goes away when it's treated correctly. We have 5 fundamental variants or subtypes of IC now. Christy says, I want to know if anyone here knows about Tarlov cyst disease. Tarlov cyst, again, coming on our theme of IC 101, it's not just a bladder disease. Tarlov cyst is the perfect example of something beyond the bladder causing problems. Because a Tarlov cyst is a little tiny cyst of spinal fluid that emerges from the sacrum. And I have let me get my model here. Oops. Right. Okay. So look, here's our pelvis, right? Spinal cord. This is the disc I ruptured. This is the disc I ruptured right there. And down here, you can see at the base of the spinal cord, you can see the sacrum. You see the 8 holes in the sacrum are where nerves from the spinal cord emerge into the pelvis, where they can either go down the legs or innervate various portions of the pelvis. Some people get something called a Tarlov cyst, which is a small cyst that basically can start pressing on the nerves that innervate the bladder, and it can cause bladder symptoms. So Christy says here, I came here 2 years ago thinking I have IC, and now I have discovered you have Tarlov cyst disease. So Christy, the question here then is, are they going to do surgery to remove the Tarlov cyst? What's the plan there? All right, here, hold on. You guys, towards the end of the meeting, I have access to a much bigger pelvic pain database from Harvard. They shared it with me. And so if you're looking for a doctor referral towards the end of the meeting, I will be happy to look some up for you, okay? Hi, Amber. Amber says, my doctors keep writing me off. I can't take it anymore. Girl, this is when you got to put your foot down, stand up tall, look them in the eye and say, tell me what could be causing this symptom. No shame, no blame. Remember, you need to be able to walk into your doctor's office ready to talk turkey. You need to know the structures in your pelvis. You need to know the muscles. You need to know the history. You never, ever walk into a second opinion and walk in and say, hey, I've got IC. Because you're going to fall down that rabbit hole of old beliefs about IC. You need to walk in and say, listen, I can't sleep through the night. I've got this weird fluttering pain by my tailbone. Occasionally I get pain shooting down my leg. Can you please help me understand what that is? Because that's probably not IC. That's probably pudendal neuralgia, right? We need to get the doctors to focus on your body, not on the word, on the body. We want a second opinion on what structures could be causing dysfunction in your pelvis that is leading to the symptoms of IC, frequency, urgency, pressure, pain. And again, one of the other things that we're really now that we know to ask the freaking question, y'all know what this is? This is your tailbone. It's the tailbone, right? And actually some infants are actually born with long tailbones. But anyway, if you can see here, I want you to look at your tailbone. Your tailbone, as it comes down your lower back and past your sacrum, it curves inward. You can see it's straight. So it's straight, but it curves inward. But if you've broken your tailbone, and your tailbone is now crooked, and instead of being curved, it's straight, that could be the source of your long-term pain and discomfort. So again, let's look at this again. I really want you to understand my language here. So the tailbone goes straight down your body, top to bottom, right? But it's curved. It curves under and inward. But if you've broken this tailbone and this tailbone no longer curves, or it angles to the left or to the right, that is not a good thing. That can actually, what that's going to do is that's going to put unusual pressure on your pelvic floor. This side, let's say if it's curved this way, this side is now going to be overstretched and it's going to be tight. And that could create the foundation for pelvic pain and, in fact, IC symptoms, frequency, urgency, pressure, pain. One of many new things that we've learned in the last couple of years. Let's see. Hold on a sec. Wait, YouTube. Wait. Angel says nothing works for me. If nothing works, that means they haven't found the problem yet. And that's what we've got to do. We have to find the problem. Anne says, your doctor said you have IC without doing any testing, then questioned it. And when you questioned it, he said, do you want an ultrasound of your kidneys? Odd. Amber says, I have the interstim and I haven't spoken to my doctor since she put it in. It's not helping. I tell them how bad I hurt too. And they say, oh, well, I seriously can't take this anymore. So Amber, haven't you had any follow-up appointments with your interstim? I mean, that sucker needs to be monitored. How long ago did you have it? I mean, you need to tell your doctor it's not working for you. You need to tell your doctor that. No shame, no blame. Maybe it can be adjusted. Angel says, my bladder hurts so badly, I can feel it when you sit down. You don't normally feel your bladder when you sit down. You can see how hot it is, guys. You can see I'm sweating. Sorry about that. It is hot here in California today. That's normally, unless you have a prolapse and your bladder is, so let's think about this for a moment here, Angel. Okay, so again, so here's your pelvis. And we can even kind of put your bladder in right here. So your bladder is normally right here, right? And here's your levator ani muscles. Really, the only way you could feel your bladder when you sit down is if your bladder has fallen and you have a prolapse. You need to tell your doctor that, hon. Prolapses are interesting because sometimes, I mean, as a woman, you can feel it. There's a hard lump at your vaginal opening that's just not right. But the funny thing is when you go to the doctor and you're laying on the table, it moves back. And the doctor goes, well, you don't have a prolapse. And as soon as you stand up, there it is. I can feel it. And you lay back down, it's not there. That's important. That's really, really important that you tell your doctor that, because you really shouldn't feel your bladder when you sit down. What you're going to feel when you sit down is your pelvic floor muscles. Amber says they didn't tell her much. I've tried changing programs and setting. Well, you got to talk to the experts. You have to talk to the experts. Chimera says, how's everybody doing? Everybody's doing pretty well. Okay, there's one thing. Christy says a Tarlov cyst is a perineural cyst. Yes, I just didn't remember that name. Thank you, Christy, for the correction. I appreciate that. Amber says, I'm sure I've broken my tailbone a few times, and I know I have a prolapse. There you go. All right, let's come back to Facebook. All right, Facebook, you guys, I'm 20 minutes behind on your questions. I'm sorry. I'm going to try to fly through them really quickly. Lucinda says, I have a urologist appointment on Tuesday. He put me on oxybutynin, also known as ditropan, for frequency urgency. But I only have that in a flare. Should I keep taking it? I feel like my flow is slow sometimes. You know, the challenge with oxybutynin is the longer you take it, the harder it gets to kind of pee. At least that's the experience that I had. I took ditropan for like 8 weeks, 10 weeks. And by that time, it actually got harder to pee because it kind of deadens the muscles. So really the only time that I personally have used ibuprofen in the last decade is if I'm having bladder spasms. It's not something that's a therapy for IC, but it might calm extreme frequency urgency, but over the long term, it just seems to make it a little bit harder to pee. Darlene says, do you feel the neuropathies are related to IC? Absolutely, hun. IC subtype 4, pudendal neuralgia. Absolutely. No doubt about it. Neuropathies are very clearly reflected in the IC patient population. Hello, Paula from 10B Wales. Hey, guys. Prince Harry and Meghan had a baby a couple days ago named Lilibet Diana, Mountbatten, Windsor. So happy for them. So happy for them. Love the name Lilibet, just after Queen Elizabeth, and Diana, obviously, after Prince Harry's mom, Diana. Sending them all good wishes, and to everybody who's having babies. Teresa says, I have terrible pain in my right hip that radiates around to the front doing housework. And if I walk too much, is it IC related or pelvic floor? Girl, that's pelvic floor. That's a bony structural abnormality. You've got a musculoskeletal issue. And really what you need to do is you need to try to find a physiatrist, somebody who specializes in muscles and bones. That's not IC related at all. That has nothing to do with your bladder. That is entirely musculoskeletal. Jenny is having a 2-month flare. Honey, I'm so sorry. We got to figure that flare out. I'd be happy to try to help you with that. You should come up. We'll be doing a Zoom meeting in 45 minutes. You come on into the Zoom meeting and let's see if we can figure it out for you. Becca says, this is where I am trying to see what is causing my IC. Had a bad flare the other day, had to call off work. Flares happen, and guys, remember, you can have lots and lots of different types of flares. You can have a diet-induced flare. You can have a pelvic floor-induced flare. You can have a hormone flare. You can absolutely have a hormone flare. Anne says, what does a flare feel like? I felt like a burning fire hose up there. Well, let's talk about that for a moment. So, and just so you know, in IC 101, we have a whole section on flares, and I have our hour-by-hour rescue plans. And in fact, let's just go through that. Here we go. Look at, here it is right here. So we've got our pelvic floor rescue plan. We've got our bladder wall rescue plan. And then we even have, I think, another one in here. Oh, we have sleep tips, etc. So again, it begins with your anatomy. It would be nice to know what triggered the flare. So let's throw out an example here. Let's say that your IC began at the age of 50 or 51, 52. You never had any bladder issues before then, never. All of a sudden, 51, 52, bam, you got frequency, urgency, you're peeing every 20 minutes, every 30 minutes. You go to the doctor, and the doctor goes, oh, you might have overactive bladder, but I think you have interstitial cystitis. The mistake that the doctor makes is they don't explain why. And in the postmenopausal women, it's all about the quality and health of your skin, estrogen levels. Your bladder is like your mouth. It's a hollow organ covered with a really thick coating of mucus. And the purpose of that mucus is to act as a barrier. It protects your skin. And so when you're young and you have lots and lots of estrogen, you have lots and lots of mucus, and you can get away with stuff. When you're older and postmenopausal, you have much less estrogen, and this means that your bladder simply cannot produce the mucus it needs to defend itself. That's not a disease. That's aging. So, so let's say you're in that group, that your bladder is compromised simply because your estrogen levels are low. And you continue to drink your cup of coffee every day, not understanding that your bladder can no longer defend itself well against that cup of coffee. Eventually, you're going to have a bladder wall flare. So Bladder wall flares are characterized by pain and discomfort as the bladder fills with urine that is relieved by urination. So the fuller you get, the worse you feel. And as soon as you pee, you feel better. Symptoms can begin quickly or more often make it difficult to sleep that night. These flares can be short or long term, especially if a patient is irritating their bladder daily with coffee or soda. So, step one, if the flare is triggered by eating or drinking a risk food, the first priority is to drink a glass or two of water to dilute your urine and to reduce acid levels and to wash out any of those irritants. Sensitive bladders don't tolerate large or sudden volumes of water well, which may painfully stretch the bladder. Thus, it's better to sip a glass of water over a period of an hour. Remember, your urine should be a pale, clear yellow. Dark yellow or brown urine indicates dehydration. Clear urine indicates that the patient is drinking too much water and could develop an electrolyte imbalance. So step one, drink some water, dilute your urine. Step two, let's just say the flare was caused by that cup of coffee or that soda. Your next step is to alkalinize your urine. Let's see if we can counteract the acid with a little bit of alkalinity. So this is where you could take a pre-leaf, right? So you could take a pre-leaf or a Tums or even like a quarter teaspoon of baking soda in a glass of water. And the goal of that is to immediately reduce the acid level. And so that makes total sense. Remember though, if you can't use salt because of heart issues or blood pressure issues, then you can't do baking soda in a glass of water because baking soda is sodium bicarbonate. Okay, step 3. Now we have to do something that's soothing for the bladder. So we want to do chamomile herbal tea or peppermint herbal tea. Why? Because research studies have proven that they have a gentle antispasmodic effect on smooth muscle, and your bladder is composed of smooth muscle. So having a nice strong cup of chamomile herbal tea, peppermint herbal tea would be an ideal next step. And we have research that proves that a strong cup of peppermint tea before colonoscopy will reduce bowel spasms. So there's good precedent there for the chamomile herbal tea. If your symptoms are continuing hour or two later, 3 or 4 hours later, the next thing you can do is try to numb your bladder wall. And the way you do that is with azo. This is over the counter. So you can get this for pretty much every drugstore and or every supermarket. You can get it from us too. So azo bladder pain relief tablets, they are the generic version of pyridium. This is the stuff that turns your urine orange or red. So it's annoying and it's weird. But what does this do? This acts to numb the skin inside you. So it will numb the bladder to a certain degree and numb the urethra to a certain degree. I'm going to say that now here's the irony, right? Now that I know that my bladder is totally normal and there's nothing wrong with my bladder other than just the fact that I'm older now. Now I know why azo never worked for me because my flares were never my bladder wall flares. My flares were pelvic floor flares. But if you legitimately have a bladder wall flare, azo, something like azo or pyridium would be the next step. You could also potentially try a few of the other over-the-counter supplements. You could do, if you like aloe, you could do Desert Harvest aloe. You could do George's aloe juice, which is the aloe drink that I think has the best reputation out there. Or you could try some aloe path. The reason why I put Allopath actually at the top of the list is because Allopath not only has aloe in it, but it has palmitoethanolamide, PEA, to reduce pain. And that's proven in research. The PEA, we had a big research study brought to the United States 2 years ago at the American Urology Association, which showed that palmitoethanolamide was remarkably successful at reducing the symptoms of pain in IC patients. So that would be your next step, would be maybe something soothing to your bladder or PEA or a combination of both, aloe and PEA, also known as Allopath. If you're not making a dent and your flare is still driving you absolutely crazy, call your doctor and ask for a rescue installation. A rescue installation will numb your bladder wall. Basically, a rescue installation is either heparin and lidocaine or heparin and marcaine, a few other ingredients in there. It's called a rescue installation. And the reason why they call it a rescue is because it rescues you out of a flare. Okay. If during this bladder wall flare you're having bladder spasms, then you want to make sure you're using a smooth muscle antispasmodic, not a striated muscle, not a skeletal muscle. You want a smooth muscle antispasmodic. We just talked about that. That's really going to be ditropan or Detrol. And then step 8, if the pain is so intense that you cannot function or sleep, then you're going to need some pain medicine potentially. Our challenge here is that many urologists are uncomfortable writing prescriptions for opiate medication, so these can be very helpful in reducing a painful bladder. Some patients have turned to hemp or medical marijuana-based CBD products, and we did an 8-year study on medical marijuana and IC years ago that showed that some patients got remarkable relief from that. So that is an example of a bladder wall flare rescue plan where you screwed up, you went to a party, somebody handed you some champagne, and it got you. And it got you. That's the protocol for that. Let's talk about a pelvic floor rescue plan. So pelvic floor flares are different. Differentiating between bladder wall pain and pelvic floor pain is actually remarkably hard to do because they all cause frequency, urgency, pressure, pain. But there are a few subtle differences. Bladder wall pain is very sharp and shrill. It feels like razor blades. It feels like glass shards in your bladder. Whereas pelvic and somebody with bladder wall injury, um, their day is dominated by access to the restroom because the fuller your bladder is, the worse you feel. So somebody with a real bladder wall issue, their day is dominated by restroom access. Get out of my way, I need to pee, it hurts bad. Pelvic floor pain is not quite as that intense. Pelvic floor pain tends to be duller, achier, and it has a burning quality to it because a muscle that's working hard builds up lactic acid and it burns. But the real difference is in urination. That if you have tight pelvic floor muscles and you try to pee, you can't start your stream right away. You hesitate 5, 10, 15, 20, 30 seconds before you can release urine. Okay, so that's the big difference. If you can start your stream right away and pee and go, your pelvic floor is good. But if you are hesitating and you cannot release urine quickly, that tells us that your muscles are tight. And that's what I do now. That's really how I pay attention to my muscles, is really how easily can I start my urine stream. It's just that easy. And I notice that when things start slowing down, my muscles are getting tighter and tighter and tighter. Okay, so let's say your flare started after sex or your flare started after a plane trip or a car ride. That's a pelvic floor flare. And I talk about the subtleness and the symptoms. The symptoms are subtly different. You may feel heaviness in your pelvis, a downward sensation as if something were falling out of you, or an upward sensation as if something was being pushed up inside of your urethra, your vagina, or your rectum. It can also feel like there's a foreign object inside your body, like something stuck up there. But the most common symptom of a pelvic floor flare is difficulty starting urination. If it takes 5, 10, 15 seconds or longer to relax enough to empty your bladder, that is a definitive sign that your pelvic floor muscles are tight. Step 1, your immediate goal is to calm and relax the muscles. So as soon as your symptoms begin, stop what you're doing, sit in a recliner or lay on your bed, grab a heating pad and put that over your pelvis. Interestingly, some people love heat and some people love cold. The heat is really focusing on muscle patients. The cold is really functioning on nerve patients. Like for me, it's all about the heat. I sleep with a heating pad every night. All right, so we're going to use heat to try to get those muscles to relax, or if necessary, cold packs. You have to figure out what works for you. Step 2, your next step is actually to use a glass wand. Hopefully you're already in pelvic floor physical therapy, and hopefully they've already taught you how to do this, that you already know how to use a glass wand to relax your pelvic floor. That's what I do. And so the glass wand is so again, I'm going through this right now with my ruptured disc in my back. And my right, it's my right knee that's messed up by the ruptured disc. I feel like I have a vice around my knee and around my thigh. And so it's affecting my right side. So that makes sense that if it's affecting my right knee, it's affecting my right pelvic floor. And like I said, when we started, the pelvic floor muscles are normally very flat, right? You can see that they're flat along the bone. But when they get tight, they lift and they tighten. And that's exactly what my right pelvic floor is doing like mad. And so what I have to do is I have to get in here with a glass wand. And you have a physical therapist who will teach you how to do it. And I will show you what I do. It's a J shape, right? So my goal here is to go the length of the muscle here. And I'm going to try to get that muscle to relax, release, and flatten. And I didn't quite understand the J shape. But if I hold this up like that, you can see it actually is a reverse J. It is a reverse J going all the way up. And it's the same on the other side. So this is the cool thing about knowing your pelvic floor, is if your pelvic floor is tight and you have a wand, you can work on it. The more you work on it, the better. This is about you paying attention to how those muscles feel. If you sit down suddenly and you get a pulling sensation, that's your pelvic floor. That's not your bladder. That's your pelvic floor. Step 3, so you've used a glass wand or you've used a dilator and you've tried to relax your muscles, but they're still hurting. So the next thing we're going to do is we're not going to do azo, we're going to do a muscle relaxant. That's where a vaginal Valium suppository or baclofen or Flexeril. It's a skeletal muscle relaxant. It's not a smooth muscle relaxant like ditropan, because that works with organs. That doesn't work with skeletal muscles. These are skeletal muscles. And so this is when we would use a skeletal muscle relaxant to try to relax these, as I did 2 nights ago when I took Flexeril. If the muscles are so tense that they tremor and shake, it's time to rest. Lie down to relieve the tension throughout the body. And anyway, we go through this with what you can do for that. But getting back to the muscle relaxant, again, vaginal Valium suppository, Flexeril, baclofen, Valium is what would relax these muscles. And then, of course, ultimately, working with a pelvic floor physical therapist is so important. It's so incredibly important so that you can identify which muscle is messed up. For me, I know which muscle is messed up. It's the upper one. It's up here. It's my piriformis muscles. Up here are the ones that are really messed up. So I was working with a patient on Friday. It was I'm telling you guys, it's like trying to get water out of a desert to get information from you. I find talking with IC patients so incredibly challenging. So here we have a 70-year-old woman who's had a severe flare for about 6 months. And bladder therapies were not working for her at all. And so we talked a little bit about estrogen and GSM, and she didn't understand why taking estrogen was important. But there clearly was something that still wasn't quite right. The way she was describing her symptoms really didn't point to her bladder quite so much. So we're talking and talking, and I went, have you ever had sciatica? And she goes, oh my God, yes, I have had the worst sciatica. It's always on my left side. And it's like, okay, you have tight pelvic floor muscles. She goes, why? Because sciatica comes from tight muscles pushing on that nerve. So you absolutely have tight pelvic floor muscles. And she'd been to a physical therapist once who told her, yes, you have very tight muscles. But then COVID hit and she couldn't go and she didn't quite understand the importance of this. So we're talking, and it's like, okay, so yeah, you got some skin atrophy, but you also have really tight muscles. So we got to figure that out. Why on earth could you have tight muscles? So we're just kind of talking about that. Like, does it hurt when you sit, when you stand, yada, yada, yada. And she goes, well, when I danced ballet, that's when it all started. And like when we think of the absolute worst risk factor for somebody to develop pelvic floor syndrome or piriformis syndrome, which is actually what she had, it's going to be football, it's going to be ice skating, it's going to be gymnastics, and it's going to be ballet. Because think about it, in ballet, I did ballet for 2 years. You are taught to tuck under. So when you look at how ballerinas are walking, their butt isn't out, their butt is under. And you do that for 5 years, 10 years, 15 years, 20 years, your muscle memory is massively screwed up. And so what was so interesting about this coaching is she's like, bladder, 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 bladder. It's my bladder. It's like, honey, did you tell anybody that you had sciatica? No. Did you tell your physical therapist you had sciatica? No. Did you tell your doctor you were a ballerina? No. And she was stunned. She was stunned. She was the perfect example of what we call the somatovisceral reflex. Can muscle dysfunction change organ behavior? She has had pelvic floor dysfunction for 50 years. Her pelvic floor's never been normal because of the ballet. And that created this cascade of all these other things happening with her. Absolutely fascinating case. So you have to work with a physical therapist. Anyway, and we have a few more tips in here in IC 101 on managing flares. We also have tips on sleep and how to get a better quality sleep. So Emily, I hope that helps you understand a little bit more about a bladder wall flare, pelvic floor flare. Now you can have a stress flare whenever you're under stress, you're in the fight or flight response. What does your body do? It raises your heart rate, it raises your blood pressure, and it tightens your muscles. And some of us live in a constant state of stress and anxiety. That's chronic overlapping pain conditions. That's a central nervous system dysfunction, which means that our muscles are constantly and frequently tight because those nerves are not functioning correctly. And we can talk about that later if somebody wants to do that. Joan says, Jill, did you see my diagnosed pain is coming from sacroiliitis? You're now getting injections at S2, S1 in your bursa on the side of your hips. Excellent. Excellent, excellent, excellent. Becky says today is her birthday. Happy birthday, Becky. I hope that you've had a great day. Amber says, Azo makes me throw up. Oh, I'm sorry to hear that, hon. We all have different medication sensitivities. If that's what it does, that's what it does. All right, let's go back to Facebook here. Hey, you know what, guys? I had a big smoothie before I started. I actually kind of need to go to the bathroom, which is really rare in these meetings. So tell you what, 2-minute break. Everybody use the bathroom and come right back. I'll be right back. righty. You know what? I am gonna. It's so hot here. I need to get my hair up. One sec. Be prepared. I'm cutting it off. It's getting cut off soon. My COVID hair is gonna go. All right. It's a beast. All right. I want to make sure this isn't too tight. It will give me a headache. I get it. Okay. I don't want to look like a goofball. It can happen. All right. Somebody asked if spinal stenosis can affect IC. The answer is sure. Sure it could. I mean, because it's going to potentially affect the nerve supporting IC. Adele says, I've had IC all my life, was finally diagnosed in my late 20s, used to get grounded or in trouble at school because they didn't believe me. You're 54 now. I don't believe it will ever change. Not as common here in the UK. It has to be the most annoying disease, painful bladder disease. So Adele, you know, when we think about the diversity in the IC patient population, for some people, IC begins in childhood. For others, IC begins after menopause. For some people, IC begins after chemotherapy. And for others, IC begins after falling on their tailbone, right? There's this huge diversity in this patient population. So in the patients whose symptoms begin at childhood, we're really looking at three potential events that could trigger it. Number one is genetics. I mean, genetics is part of mine, right? I mean, hello, redhead. If your mother had frequency urgency, if your sister, if your grandmother, if aunts, uncles, cousins have a history of frequency urgency, that would put you squarely in IC subtype 5, chronic overlapping pain condition, central sensitization. But if you, for example, fell on your tailbone as a young child, or you were hit by a car as a young child, you would be a physical trauma patient, right? And in that context, we're really looking at muscles and bones. I remember I was working with a gentleman who lived up by Lake Tahoe who had been hit by a car when he was 8 or 9 years old, and he'd actually had his pelvis crushed. I mean, it's kind of a miracle he survived. And his entire life, he's had quote unquote IC symptoms. And it all goes back to that original fundamental injury that happened here where these bones were crushed. And clearly he has a lot of scar tissue, a lot of adhesions, and he probably has some bones that are out of position. And so we have to look at the potential role of physical trauma. And then to a much lesser extent, we would be looking at chemical injury. I remember I was working with a mother of a daughter who had IC in the Midwest. And not only she had IC, she'd been diagnosed with eosinophilic cystitis, which means that her bladder wall was filled with white blood cells. And you can also get eosinophilic lung disease. And in her case, what they were able to trace that to was a contaminated well water. Their well water on their farm was contaminated with pesticides. And once they were able to resolve that, I think things improved tremendously. Tabitha says she's scheduled for trigger point injections on her pelvic floor. It sounds so painful. I'm not sure. Oh, girl, honey, you are so freaking strong. Why are you thinking you're weak here? You are a tough cookie. A trigger point injection you can handle. You can handle. Guys, seriously, if you're here today, you have never been more prepared to deal with whatever happens with you than you are at this very moment, because you are truly one day older and one day wiser. You can handle a trigger point injection, and if there's a chance that they can resolve that trigger point and improve blood flow, you gotta at least attempt it. Don't be afraid. Let's think positive here. Let's do some good visualizations before that. When you wake up that morning, visualize in your mind how that appointment's going to go. You're going to wake up feeling good, feeling confident. You're going to imagine yourself getting dressed, having a great breakfast. Your ride is there if you're not driving yourself. You have a fun conversation in the car with who's ever driving you. You get to the doctor. The receptionist has a smile on your face. Hey, it's Jill. I'm here. They go, hey, Jill, it's so nice to see you. We are ready for you. Visualize that appointment going well. They take you back into the room. Everybody's happy. You're laying on the bed. You're ready to go. The doctor comes in, super, super happy. And then visualize it not hurting. That it's, oh, you're done? Wait, you're done? Well, that was easy. It's kind of like when I had my SI injury. I was afraid to have my SI joint steroid injection. I didn't do it for like 9 months. He was in and out in 5 minutes, and I didn't even feel it. It was like literally one of those. You're done? Oh my God, that was so easy. So imagine, visualize that the injection is super easy. Visualize that as you walk out, you carry hope, you feel good, you feel hopeful. Visualize that night that your trigger point feels better, your muscles feel better. Don't assume the worst, assume the best. Practice good positivity here. Okay, now you guys on Facebook, it's going by really quickly. Hold on, let me see if I can lengthen this a little bit more. There you go. And look at that. You can see my, all right, something's hanging off up there that's not supposed to be hanging off. Is that going to fix it? All right, that's going to fix it. Sylvianne says, my doctor wants me to have a pelvic vaginal sonogram, echogram. Something tells me it's not a good exam for someone with IC. Why would you be worried about that, hun? Information is power. If that will allow them to see if maybe you have a fibroid tumor, if you've got endometriosis, if you got something else going on, I mean, you can't expect them to guess. Don't force your doctor to guess. You have to give them the opportunity to examine you. And if you're worried about a test, ask them about it and say, is this going to make me better? Is this going to make me worse? Is there a potential side effect? But information is power here. It's data. It's important information. The worst thing you can do is not allow the doctor examine you, because you are forcing them to guess. And that's never going to end well for you. Like the woman who didn't allow her doctor to do a cystoscopy for years. Finally, she got so freaking severe, she was like, okay, you can do it. What'd they find? A bladder stone. A bladder stone in her bladder, so large and so sharp, as it was floating in her urine, it was cutting her bladder. She had it for years. And as soon as they broke it up, what do you think happened? Her bladder healed. She was symptom-free and cured. She endured pain for years for something completely treatable if she just let them look in her bladder. Melanie's asking about Allopath. Allopath is one of the newer supplements. It's a combination of organic anthraquinone-free aloe with PEA. It's very popular now. It's very, very popular because it has a soothing effect from the aloe with a pain-fighting effect on the PEA. Shannon says, amitriptyline is causing me to eat at night. Is there anything else I can take that will help with overall pain that won't cause me to be hungry? So if you look at the American Urology Association guidelines for IC, they have 6 steps of treatment. Now, the AUA guidelines were created before we started using subtyping. Subtyping is really only in the last 5 years. The AUA guidelines were invented in 2011, 10 years ago. But the AUA guidelines are they're still good. We're just a little bit more targeted now, but they are arranged with respect to the risk of adverse event. So they have 6 steps of treatment. The last step is surgery. We don't want you to do surgery until you do the easy stuff. So in the AUA guidelines, the first step of treatment is drinking water, relaxing muscles, and trying supplements, because the supplements, according to the AUA, have fewer side effects than amitriptyline. Amitriptyline is a step 2 treatment. It's an antidepressant. When taken over time, can help calm nerves down. But amitriptyline is a beast of a medication to take. It can cause rapid heart rate. It can cause irregular heart rhythm. I had both of those when I took amitriptyline. But one of the bigger challenges is extensive fatigue. It's pretty hard to be alert when you're on amitriptyline. And unfortunately, weight gain. Amitriptyline makes you eat carbs. You snack. And so we call it the amitriptyline 20. I gained 20 pounds on amitriptyline in less than a month. Like, bam, there it is. Like, oh my God, what the hell happened to my stomach? And that is what a low dose antidepressant can do. And so the AUA says, listen, let's not start the tricky, hard stuff. Let's go with the easy stuff first. So, what the AUA would say is, hey, have you tried the supplements yet? Have you tried the supplements? Oh, and I have another Cystoprotec update. Let me show you the supplements here. I have another giveaway too, guys. If you're willing to stick it out with me, the price of my giveaways is you gotta stick around. All right. Whoops. Wait. Come here. There you go. So when we think about supplements, we're really thinking about IC subtype. Well, it depends upon what we're trying to accomplish. So if your IC is due to estrogen atrophy or chemical injury to the bladder, we're going to want to do something that has a bit of a coating effect. And so the ingredient to look for is chondroitin. I had a research study presented a year ago, at the European Society for the Study of IC that showed that chondroitin was the most effective at restoring the superficial integrity of the bladder wall. Now, that was a study of bladder installations. It's just like and so all we can do is kind of extrapolate that back to kind of oral medication. It's not perfect, but that's the best we've got. So the typical supplements that contain chondroitin, and I'll do them in order of popularity here. Bladder Builder, because Bladder Builder also has PEA in it for pain relief, as well as some beneficial probiotics and things like that. But if you flare with probiotics, we would take this off the table. So then we would be looking at Bladder Rest, which is a really clean, pristine formula for people who are a little bit more sensitive like I am. And so this has chondroitin, L-arginine, quercetin, with some L-citrulline and some vitamin D3 and K2. And this is in an avocado oil base to make it a little bit more heat tolerant. Or Cystoprotec. And here's a reveal. Our first reveal, new label. Old label, new label. Red pill, brown pill. So remember, we couldn't get Cystoprotec for almost 6 months because of the COVID-related manufacturing delay. In the meantime, Algonaut, the company that invented this, has purchased it, or they've reinforced the contract and they've taken it back from Mylan. Unfortunately, they produced several thousand bottles of this label, and they were hoping they would be able to relabel them, but they can't. So we got like 500 bottles of these, and people are like going, wait, it's a brown pill, different label. But guess what? We're going back to these. When we get our big order, we will only have these until those thousands of bottles are done. And then it will only be this. So there's still more confusion with Cystoprotect. Whether it's the red capsule or the brown capsule, the ingredients are exactly the same on the inside. The only thing that's different is the capsule. Now let's do this right now. Guys, I have 2 bottles right now that expire in September. These expire in September. I am happy to give these away. If you love Cystoprotect and you have not been able to get it and you're willing to take something that expires in 3 months, I will mail these out to you tomorrow if anybody wants a bottle of Cystoprotect, okay? So, if you want it, you need to email me, icnetwork@mac.com, that you would like Cystoprotect. I need your mailing address. And do me a favor, throw in your best flare management tip. Your best flare management tip, okay? And this one I opened because I was the one who discovered the difference. So for this one, it's a brown capsule. But for, I think I have. Versus a red capsule. Okay. All right. So if anybody wants a free bottle of Cystoprotect, icnetwork@mac.com. I want to get them off on my shelf. There you go. Let's do another giveaway because I'm feeling really happy today. Anybody have super sensitive skin like I do? Like you can barely tolerate laundry detergent? Oh gosh, hope I didn't show you my underwear. Sorry about that if I did. The Echo Egg. David Bauman, first one to send me an email. David, you will get one of these Cystoprotects. Anybody want to try an Echo Egg? If you want an Echo Egg, which is a mineral-based laundry detergent, I use them myself. I got 2 of these. I'll be happy to send these out too. icnetwork@mac.com. I just need your address. Okay, hold on. I got to adjust here. I'm not sitting right. Okay. Where can you purchase the book IC 101 from the IC Network store? Just go to icnetwork.com. All right, hold on. I have our 2 winners for the Cystoprotect. I need to post it. Where are my Post-its? Here we go. I'm going to write your names on these. All right. David, that's yours. All right. David and Anne, I can't send it to you without your mailing address. Oh, but I know, David, I know I have your mailing address. And there you go. Okay, so Anne is going to get the second Cystoprotect. Margaret or Cindy is going to get an Echo Egg. And I don't know, maybe I'll just throw in an IC 101. We'll see. We'll see what my boxes will hold. All right, Carol also wants an echo egg. All right, Carol. You have to, Carol, you have to send me your mailing address, hon. All right, good, good, good. It's a potty. We're having a giveaway potty. Stay. Okay. The other supplements to continue this discussion, Sister Renew. Sister Renew combines chondroitin with quercetin, L-arginine, L-citrulline, but it also adds a little bit of aloe and a little bit of lemon balm. Lemon balm is known for its kind of nerve calming effect, but if you're aloe intolerant, you can't do this one. Aloe Path, which is the calming and soothing effect of aloe with the pain fighting ingredient of PEA. So aloe, if you like aloe and you've taken it for years, but it's just not, you have a little bit more room for improvement, it'd be very interesting to add some aloe path to that mix. And again, everybody's different. Some people are sensitive, some people aren't sensitive. It's just at least unlike 25 years ago, we didn't have any options. At least now we have options, right? We have some things to try. And then people always ask me what I take. This is what I take, Peora, because my bladder wall is fine. There's nothing physically wrong with my bladder wall. It is my central nervous system. And so Peora doesn't do anything for the bladder wall. It calms nerves down. And the way I know that my central nervous system is starting to get really wonky is I get random pinpricks, especially as I'm trying to go to sleep. I'll get a pinprick in my leg, a pinprick in my thigh, in my arm, in my belly, you name it. It's just completely random. And as soon as I start feeling that, that's when I take this. But I just take 2 at night, and I don't get pinpricks anymore. I mean, my pinpricking in my skin used to be so bad that I couldn't sleep, and I'd have to take some Vicodin to try to sleep. It's gone with PEA. And that's what that research study showed. The PEA resveratrol research study, IC study, found that by month 3, 87% of patients using PEA had a significant reduction in their pain. And by 6 months, a group of them were pain-free and the rest were doing remarkably well. So Peora is really ideal for patients in IC subtype 5 as an option. And of course, one last thing is we do have a low acid vitamin because traditional vitamins really hurt because of the ascorbic acid. And so low acid vitamins were actually my idea. I actually had the CEO of Farr Laboratories 15 years ago say, Jill, if you could make anything for an IC patient, what would you make? I went, I know exactly what I'd make. I'd make a low acid vitamin because every single day I have patients asking for a bladder friendly vitamin and I had none. And he called me back 6 months later and he said, we made you a low acid vitamin. And that was called Multirite. The original low acid vitamin was Multirite, but it was a horse pill. It was way too big. And so I asked Natural Approach Nutrition if they would make a smaller one, and they did. And so instead of one giant horse pill, you take 1 or 2 or 3 of these capsules, depending upon what you want. And never flared from this. Yet a 1 a day or Centrum killed me. And again, that's from my fundamental problem is my pelvic floor. My pelvic floor has led to very sensitive nerves, and it's the nerves that are the ones that get messed up. Let's see. Let me check YouTube here. Mickey says, my urologist put me on gabapentin, which made me faint, and I broke my tailbone on the corner of the wall. Oh, honey. Oh, the irony. You know, we have had some patients whose frequency was so bad, they would literally be sleeping they'd be on their toilet and they'd sleep on their toilet and they'd fall off their toilet and hit their heads. It's we really want to try to deal with the fundamental problem here. Katie says, help, talk about the pudendal nerve entrapment procedure. So nervous. Well, what are they going to do, hun? Yeah, we don't. Yeah, as David says, don't cut. You're not going to, we're not talking about cutting nerves. That would be very, very extreme. We want to try to figure out where the nerve is entrapped and do the correct physical therapy, or maybe in nerve blocks. A nerve block is another way to diagnose a pudendal nerve entrapment. Christy said, it's really hard to know where mine is coming from. I've had several UTIs in the past 5 months. Now after several antibiotics, my cultures are negative, but I have all the symptoms of a daily UTI. I also have spinal stenosis. So, Christy, it would be really interesting to know the type of infection you had. I mean, were they proven? Were they documented? And did they identify it? If it's the same bacteria over and over and over again, E. coli, for example. It could be that you have a drug-resistant form of it, or it could be that you have something in your daily life that's exposing you to it, like jets in a bathtub. That would do that. Some infections are coming from food. You know, when people think bladder infection, you know, we women have all gotten the lecture on, are you wiping from front to back and cleanliness? And there's like this disgusting message that you're dirty, when in fact, you know, some of the worst infections are actually coming from food. They're coming from food, beef, chicken, that have been overtreated with antibiotics. And they've now developed these super resistant E. coli infections, like the whole Costco chicken fiasco that happened years ago. And there's also a chance that you could have a chronic infection. You know, I'm a huge fan of next generation DNA urine testing, because I like data, I like facts. And, you know, some of you absolutely believe that you have infection. I believe for my first year or two that I had infection. I can't tell you the number of urine tests I had every time I flared, thinking that it was UTI, even though the test came back negative. When you have a next generation urine test, they're not trying to grow anything. Instead, they're looking at DNA that they've isolated in your urine, and they will be able to identify everything in your urine: good bacteria, bad bacteria, fungus, and even potentially virus, if you have the viral test. And that's kind of the test that will tell us once and for all if you've got something really unique, different, challenging, like a super resistant E. coli infection. All the COVID testing that's being done is next generation testing. The MAP Research Network, which is the National Institutes of Health funded IC chronic prostatitis research network, that's done fabulous work. They use next generation testing in many of their studies. They're the ones who discovered that some patients have chronic fungal infections. You're flaring. If you flare when you eat sugar or you eat ice cream or milk, you have a candida in your urine potentially. And it was our own National Institutes of Health who proved that. And a typical urine test does not grow fungus. And so some of you, yes, you have infection. You have all the freaking symptoms of infection. It hurts like hell. And you go have a typical urine test and it's negative because it's not testing for the right thing. And that's why next generation test is reasonable. It's reasonable to get that data. It's just data. And if that comes back and says you have candida, then we know, Christy, yeah, you do have a UTI, but it might not be bacteria. It could be fungus. So given the fact that you've had several UTIs over 5 months, it would be reasonable to take your testing up a level to see if they find anything else weird in there. Christy, also understand that as we get older, we become more vulnerable to infection because of the loss of estrogen. Your skin doesn't have that nice thick barrier that normally protects it. And so if you're perimenopausal, menopausal, postmenopausal, surgical menopause, whatever, chemical menopause, whatever, your bladder simply cannot defend itself. It cannot defend itself. And so using something like Prevent or Allura might be helpful. They are, or D-Mano. So Prevent is a proanthocyanidin product with D-mannose. And so it's like Allura. It's actually a little bit stronger than Allura. And Allura is very popular. So this is something that Dr. Ken Peters asked the people who made Bladder Builder if they would make something like that was affordable. And that's what they've made. And they're getting great. In fact, they have their first TV commercials coming up. Pretty exciting. So you can find Prevent in our store if you wanted to do it. David, I just put the book in our store on Thursday, and I haven't even sent out my email about it. This is the first time we are talking about our brand new book, IC 101. It's not just a bladder disease. 2-year effort. And this is about opening your eyes far beyond the bladder to the other things that can also be involved. Melanie says, so Bev says she'd like to get the book, but she would like 3 doctors to get it too. I can't send it to 3 doctors, hon. I might be able to send it to 1 doctor. Each book, just so you know, it's $17 in printing because we're printing in the US. So if you wanted the paper version, we're selling it for $24.99, but 17 of that, actually a little bit more than 17, just goes for the printing job. So you can call me and we can talk. All right. Melanie says, this is something I never thought of. I broke my tailbone when I was 11 years old. I was also a chronic bedwetter, suffered with UTIs as a kid all the time. Now I'm thinking I had IC the entire time. I was always sick. I got officially diagnosed in 2009. In 2005, I had a prolapse uterus and the IC symptoms seemed to be worse. Hence why I finally went to a surgeon. So I think the tailbone injury, the fact that you had significant trauma when you were a child is really important. You guys, seriously, when you're talking with your doctors, especially for a second opinion, you got to go back in time. You have to go back in time and try to remember those traumas. Did anything happen? That's important. What sports did you do? Did you take any injuries? Do you remember any bad falls? It's all important information for that doctor and for that physical therapist. Melanie says, is there red dye in any of these? No, the red dye in Cystoprotec is from annatto. It's a natural red dye. It's not a chemical red dye. Katie says, please answer me. Katie, I think I did. What are my thoughts on PNE? So I don't know what PNE procedure you're referring to. Botox is viable. They can inject Botox into your bladder wall. They can inject Botox into your trigger points. You have to give me a little bit more information. A little bit more information before I can comment on that. Our website address, icnetwork.org or ic-network.com. Marcia says, I have a question about using vaginal suppositories for pelvic floor tightness. I will be using combination of baclofen and gabapentin and want to know if I do not feel relief in the vaginal spasms immediately from it, is it something that has to build up? Well, the baclofen or the vaginal Valium should work, within 30 minutes to an hour. I'm not sure what the time span is for the gabapentin. I think you have to work up with the gabapentin. I don't remember. Melanie said, I tried the vaginal Valium suppositories and had the worst pain. So it sounds like you reacted to one of the chemicals in the suppository. Or, hun, again, if you've got estrogen atrophy, any chemical that you put up there is going to hurt. Any chemical is going to hurt. And so using a topical estrogen cream is going to hurt the first couple of times. It's going to feel very, very hot. But if you continue to use it, your body starts to produce mucus, which then improves the skin, and the heat gets less and less and less. So I have to wonder if you're either reacting to a chemical in the suppository or your skin is so dry, you just can't put anything on it right now. Joan said here on YouTube, yes, I recalled my sledding accident. I hit a small tree between the legs. My brother dragged me home in a sled. Mom never went to the doctor, but you bled for hours. Girl, you'd be amazed at the number of people I've talked to who've shared similar stories. Sylviane says, you're such a big help, Jill. You just have no idea how much. Well, we try. We try. Christy says, will estrogen cream help? Absolutely. Estrogen cream will, a lot of people say, what can I take that will heal my bladder? And the answer is nothing is going to heal your bladder. Only your bladder can heal your bladder. So if you give your bladder something that will help it protect itself, that's the best case scenario, because you're giving your bladder something that it needs to be healthy. And that's what estrogen is. When you use a little bit of topical estrogen on that skin immediately starts to use that estrogen to produce mucus. And that's a very good thing. Our challenge here is that if you are much older or you've been menopausal for some period of time, man, that estrogen cream in all likelihood is probably going to burn. And you're going to go, oh my God, I don't want to use this. The burning is a direct reflection of the quality and health of your skin. The drier you are, the more anything down there is going to burn. And you have to ride through it for like 2 weeks. If you don't use it, you're just going to get drier and you're going to get stuck in a vicious circle. Whereas if you can just kind of ride it out, like the first time I used estrogen cream, it burned for, 45 minutes. Then the next time it still burned, but maybe for 20 minutes. Within 4 or 5 applications, it was like a warm puff of air. It's like a puff of air on my vulva. And it was that quick. And if I forget to use my topical estrogen, the burning comes right back. So that topical estrogen is remarkably helpful for genitourinary syndrome of menopause. Of course, patients always have the concern of cancer. The advantage of the topical estrogen is that it's the estrogen stays in the skin. It is not like oral estrogen where you take it by mouth and it distributed throughout your body and can contribute to breast cancer, cervical cancer, ovarian cancer, etc. The advantage of topical estrogen therapy is that the estrogen tends to stay where you put it and is considered remarkably safe. But don't believe me, Google it. Topical estrogen safety. And you look at those research studies and you see what you think. Topical estrogen safety. Carol says, I'm having steroid injections for 2 discs in my lower back with annular fissures. I don't know what that is. I'm having a hard time telling if the pain is all that or my Hunner's lesions with urethral pain flaring. I'm having pain in my groin and my legs. So girl, I feel your pain because I'm there too. So the thing with the disc, I mean, the way they explained it to me is it usually affects one leg or the other legs, usually one-sided or both-sided, unless you have, oh, what's the word for it? A more severe spinal injury is an injury that leaves you incontinent, and that is considered an emergency. And that's when they want to do surgery right away to make sure that there's nothing pressing on that nerve, which is affecting your ability to have bowel movements and to urinate. So Jenny's having pain with intimacy. So Jenny, generally intimate, when you have a pain with intimacy, and that it feels like menstrual cramping with bad urgency, definitely want to have a pelvic floor assessment, because that's muscular. That's not bladder. That's more of a muscular symptom. And I would bet that you probably have something called vaginismus, where you probably had tight pelvic floor muscles for some time. It's, if sex is painful, if having a speculum put in there is painful, that means you've got tight muscles. If you can't start urinating right away, that means you have tight muscles. If you have pressure, if you feel like something's falling out of you or something's being pushed up inside of you, that is tight muscle. That is a tight muscle. Margaret said, I had a compounding pharmacy mix my estrogen with a soothing natural mix, not the usual pharmaceutical crap, and it did not burn. Excellent. Love it. Deb says, what are they doing now instead of Elmeron? Supplement. There's nothing. You can eat. You can do Elmeron installations, which would keep the medication in your bladder if you're that attached to Elmeron. Most people are not that attached to Elmeron. Or you go over to the chondroitin-based supplements. I have an Elmeron transition guide right on our website. Right on the front page, there's a link, Elmeron transition guide, to show you all the options you can do if you're trying to get off of Elmeron because of the eye disease issue. Ellen says, how does the estrogen help the bladder and the urethra? Think about it for a moment. The bladder is the only organ in the human body designed to hold toxic waste, because urine is body waste. Urine contains ammonia and urea and all sorts of irritants, right? So how does the bladder protect itself from those irritants? The answer is that your bladder is like your mouth. It is a hollow organ covered with a really thick, wet coating of mucus. We call it the mighty mucus. And the purpose of that mucus is to act as a barrier. It prevents urine from reaching the fragile cells and nerves of your bladder wall. Unfortunately, that mucosal barrier is estrogen dependent. So when you're young and you have lots of estrogen, you have lots of mucus and you can get away with stuff. When you're older and you have much less estrogen, you have much less mucus, guess what? Your bladder cannot defend itself. That's not a disease, that's aging. And so when you have a thinner bladder, thinner mucosal barrier, the foods that you eat are going to be more irritating. And that really surprises some people who in their 20s, 30s, 40s, they love their sweet tea in the summer. And all of a sudden in their 50s, their sweet tea kills them. Why? It's not a disease. It's just that you don't have as much mucus because you're going through the change. So using a topical estrogen at the urethra, oh, and I should say the urethra is the canary in the coal mine. The first part of the urinary tract to really start screaming with lots of estrogen is the urethra. And it will feel like there's a drop of urine stuck in your urethra that won't come out. Your urethra gets really, really irritated. That happened to me when I was 51, 52, somewhere in there. And so generally what they will have you do is rub a little bit of estrogen cream right into your urethra, along with using it vaginally. All right. So let's start our Zoom meeting. So in the Zoom meeting, what we do is people can come into the Zoom meeting and ask questions and tell your story and get a little bit of coaching from me. I have no sweat in this. If you want to do it, that's fine. If you don't want to do it, that's fine too. But let me just go ahead and start the Zoom portion of the meeting. The way I'm doing that is I'm going into our main website, icnetwork.org, going to the support pull-down menu. The second link is streamed support group meetings. And I'm going to click on the Zoom link. We're a little bit late, about 20 minutes late. And I am starting up that stream right.
Recording in progress.
All right. So it does, you guys, it does record it on my computer. Actually, I'm going to stop it.
Recording stopped.
But I don't use it. I just delete it. So don't worry about that. So in the Zoom meeting, I will let you in one at a time, or I will call on you one at a time, and I will let you into the room one at a time. And so let me grab the invitation, and I'm going to post that one on YouTube. If anybody in YouTube wants to come in and ask some questions, there you go. I'll tell you this. That's going to be my first giveaway. It's somebody in Zoom who might want the IC 101 book. Hello, Lisa. Long time no see, girl. How are you? All right. So let me get this link for Facebook. Give me one sec. All right. So on my other computer that's running the Facebook stream, I'm doing the same thing, and I'm just going to copy this link, and we're going to put it right in our Facebook stream. All right, there you go. So this is going to be our first round of giveaways for the book is going to be in Zoom. If anybody wants to do it, if you don't want to do it, that's fine. I got no sweat in this at all. Your choice. Hello, Cindy. Cindy's coming in. So when we're in the Zoom meeting, Facebook and YouTube are up. You guys are going to hear it, but you won't see it. All right. Hey, Cindy, how are you, hun?
Hey, I'm good. I just wanted to say hi. I have a kidney stone right now, and I just have a question about that.
Okay.
The stone doctor said that it's driving my UTIs.
Yeah.
Is that, yeah?
Yeah.
I have to get it out on the 24th.
So what's so interesting about stones is that they're crystals with a lot of sharp edges. They're not a round, smooth stone. They're very jagged. And that's why stones are so painful sometimes, is as they're passing, the sharp edges are actually cutting you. But the one thing they've found is that those stones are covered with bacteria. Massive bacteria. And it's not just one strain. It's like every strain in your body is almost living on that stone. It's so fascinating the way that is. And so he's right. He's right.
So, and I wanted to ask too, because I got the next gen, I ordered it and I got it. Should I wait till after I get the stone blasted to do it? To do the next gen? Or
I think I would. I mean, I kind of 6 of one, half a dozen of the other. I mean, the challenge is when you've got the stone, it's cutting your bladder wall and it's already introducing bacteria inside your bladder wall.
Oh, wow.
Okay. I
Okay.
mean, it's like physically pushing it into your bladder wall, for lack of a better example. So if you are having a bladder infection now and you have fever now and something like that, I would do the next generation now, because identifying that bacteria correctly, I think, is really important.
Mhm.
But
Well,
if
I just got off of antibiotics.
okay,
So
what did they say it was?
the infection,
Yeah. Yeah.
he didn't say. I was on my way to my son's for the weekend, and he called and said I had an infection, to hurry up and get medication. I didn't even ask.
Okay, so
Just
so that's something you absolutely need to start tracking, is we need to know what the infection is
what it
over and
was.
over and over again.
Okay.
Okay, because if it changes,
Hydrated and
whoops,
eat.
here, hold on a sec. If it changes over time, then that means, that kind of speaks potentially to an immune issue. But if it's the same bacteria over and over and over, that speaks then to perhaps something in your daily environment that could be a source of contamination. And then,
I still self-cath too.
well, there you go. Yeah.
Yeah.
Is that getting better at all?
I'm able to go on my own, but when I told the doctor, my urogynecologist, about that, she said that's why I was getting infections, because I wasn't using the cath every single time. I don't know.
And yet some doctors would say the reason you're getting the infection is because you're using the cath and you're pushing it inside your body.
Right.
So you're you're damned if you do and damned if you don't.
Exactly.
If you don't
it's very
yeah.
confusing. It's very confusing.
Are you
because I can go on my own, but I do retain.
okay?
But I went to another doctor who said you need to use this bladder on your own if you can go, because it'll start relying on the cath.
Right.
So I don't know. And then I got a kidney infection, or a kidney stone. So it's like where to start, and
Yeah.
it's challenging.
Well, yeah, I feel your frustration. There's no doubt about that. I mean, that doctor is right. That we definitely want to make sure that you're using your bladder as often as you can, because we want to keep your urinary tract as healthy as possible and as
Right.
functional as possible.
Functional.
Right?
Exactly.
Are you on Allura? Are you on anything like that as a preventative?
The problem, okay, so I was using ClearTrack.
Okay.
The problem with me is I had a surgery 5 years ago, and I have issues with my esophagus. At the lower part of my esophagus, it slows down. So any big pill
Right.
gets stuck.
Yeah.
So I have to be really careful what size pills I take.
So the D-mannose powder you can do.
Yeah.
Okay.
Yeah. Should I do that like every day?
Yeah. I mean,
Okay.
that's what some women have to do. That may be the perfect. I mean, it's not as good as a PAC product, but the D-mannose powder you can dissolve in water and you can swallow.
Mm-hmm.
And ClearTrack
Okay.
makes a D-mannose powder.
Yeah, I got it off the website. So
yeah, and
I'll just.
Yeah, the human body does not use mannose, so I mean, it is immediately excreted. What does it say here? Do I even have it here? Hold on. I don't even have it on my shelf.
I have it.
Okay. Oh, here it is.
Okay.
I do have it right here. So we're referring to ClearTrack, and then there's another aloe one that we're bringing in that is.
Is it a powder too? Oh, that's awesome.
Yeah, My Daily Mannose.
Okay.
So this is going to be
that.
the one we're going to be doing in the future, but I think we still have some of this. So what does this say? Mix 1 scoop every 2 to 3 hours into water or any beverage. Take during waking hours for the first 3 days or as needed. Those with frequent problems may use a maintenance dose of 1 or more scoops daily. Yeah. So I think that would be, given your very, very unique situation where you literally are damned if you do and damned if you don't, doing a preventative like DMANOS, this is considered, I mean, you can look at the research, but it's considered remarkably safe. Are there any
Can you
warning?
take that? Like he wants me to take, the kidney stone doctor wants me to take an antibiotic once a day. And I don't want to do that either. Like
Well,
that's awful.
but as long as you have the stone, you're kind of screwed.
Yeah.
Once the stone is gone, it would potentially be hard to justify the antibiotic. Although that is a here, hold on a sec. I just got a new book. Hold on. Okay, so I just got my copy of the Menopause Manifesto by Dr.
Yeah.
Jen Gunter. And of course, I went immediately to the bladder section. And let's just see what she has to say about, here, hold on a sec, about antibiotics. And I know we've got John, Kayleen, and Christy. You guys, I'll be with you
Yeah.
right in a sec. Let me just do this one thing here. Where is it? Bladder health, breaking the culture of silence. All right, page 179. She did not talk about interstitial cystitis in this. I even went to a talk she gave and I asked her about it. And okay, here we go. A UTI is an overgrowth of bacteria in the urine that leads to inflammation. The main symptoms are pain with emptying. Okay, we all know that. Recurrent UTIs are diagnosed when a woman has 2 infections in 6 months or 3 in a 12-month period. Recurrent UTIs will also increase with age. Before menopause, up to 1/3 of women will have a second infection with 12 months. But for women after menopause, that jumps to 55%. Despite the increased risk, this is poorly understood, related to low estrogen. She says, the increased risk of UTIs after menopause is largely related to low estrogen, which results in a variety of changes that facilitate those infections, such as a reduction in blood flow. The tissues themselves become more fragile, and the protective bacteria in the vagina is replaced with bacteria more likely to cause infection. Strategies to prevent. Strategies to prevent recurrent UTI are important, not only to reduce pain and suffering, but to reduce exposure to antibiotics, as these medications can cause collateral damage. So she said, number 1, vaginal estrogen, D-mannose, methenamine hippurate, which turns the urine, it's converted into formaldehyde in the urine. And then on antibiotics, she says, typically antibiotics are given for 3 to 6 months, and then the need is reassessed. The antibiotics commonly used are trimethoprim combined with sulfa, nitrofurantoin, cephalexin, and fosfomycin. Other interventions, cranberry, which of course is hard for us with the bladder, vitamin C, which acidifies the urine. That's going to be hard for your bladder. Probiotics. And there you go.
Okay. Can you show me the book again?
The Menopause Manifesto.
Okay. Let me see if I can get that.
And the first line is just hysterical. Menopause, let's see. Hold on. The first line of it is, if menopause were on Yelp, it would have a 1-star review. And the review would say, this establishment has temperature control issues, drenching heat followed by terrible chills. It defies the laws of thermodynamics, would not recommend.
For real.
Yeah, awful. Bleeding was scheduled, but was rebooked without notification. So arrived 3 weeks later than expected. While I was in an Uber and I flooded the car, the driver gave me a terrible review. There you go.
Thanks a lot, Joe. I'll have to look for that. That looks good.
Yeah,
I'll
it
let
is very
everybody
good.
else talk. So.
All right. Thank you,
Good to see
hon.
you. Take care. Bye-bye.
All right. I think the next one who was in was Christy, right?
Hi, Jill.
Hey, Christy. How are you, hun? How is life?
Well, trying to hang in there with all this going on, trying to find different things that might help me.
Okay.
I'm the one who kept having the urinary tract infections, and I really didn't have much pain with those, but they kept finding them and kept treating me, and they were different, all different bacteria
Okay.
each time. I've gone to pelvic floor physical therapy before for my back, and that really does help, but I can't get in till August now again, which is awful. I'm trying all different kinds of stuff, desert, aloe, what else? D-mannose, but I looked at it after I took it, it has cranberry in it, 10 milligrams.
Wait. Which one?
It's D-mannose.
You have to look at the brand. What's the brand?
Something, oh God, I gotta go get it.
So the one that we really recommend is My Daily D-mannose.
My Daily D-mannose.
Right.
I don't know. My doctor gave me a prescription with it just said D-mannose, and I called and I said, well, which one? They go, well, anyone, just follow the directions.
Yeah.
I'm like, great.
Well, neither
This
one.
one has 10% or 10 milligrams of cranberry.
Yeah,
in it.
you just bought the wrong one, hun. That's all.
Yeah.
Can take it back.
Yeah, I'll send it back to Amazon.
Yeah,
after I open it.
absolutely. No, that's a cool thing about Amazon is the customer is king on Amazon. You can return it.
And I'm not sure if the aloe is working at all. I mean, it feels somewhat better, but I'm just feeling sick. I'm feeling very tired. I also have an anal fissure. So, I mean, I don't know where all this came up from, but yeah, it's a bad situation. But I wanted to ask you about that next generation test.
Okay.
Is that something that most doctors know about, or?
Well, they know about it, but there's lots of different opinions about it. You know, HMOs do not like it because they don't want to pay for it.
Right.
So Kaiser Permanente, for example, they do not want to hear one thing about a next-gen test. And it's sad because their own infectious disease specialists use it, but the regular doctors are being kind of discouraged from using it. And that's true with a number of HMOs. But at the research level, it's extremely common. And or if you're seeing an infectious disease specialist, that's also extremely common. So
that's an idea.
Well, you know, you order the test yourself. You order the test. Microgen is one company that does it. And you pay for it out of pocket, $199. Or if you have Medicare, it is approved by Medicare. It might take longer for you to get it. They send the kit to you. You collect the data, and there's a form that you have a doctor sign so that the doctor can get the results.
Okay.
And so it can be any doctor. It can be your primary care doctor. It could be, and then if you don't have a doctor, you can talk to Microgen. They have doctors in every region that work with patients.
Right. I bet you I go to an alternative medicine physician, actually integrative medicine.
Right.
And she probably will know about this test.
Well, I mean, it's data. And you know, the obstacle that faces so many IC patients is that their diagnosis is based on a guess.
Right.
It's like you have frequent.
I just had the cystoscopy and everything looked fine.
Right. Okay. So what does that tell you then? That your bladder?
It's not my bladder.
Right. Right. It's telling you that your bladder structure is intact. Your bladder looks good. Your bladder looks healthy. So we have to look outside of the bladder to other things that are influencing your bladder, hun. So we start with the pelvic floor. We're going to look for fibroid tumors, endometriosis. You know, and that
I've had a total hysterectomy, so I have no hormones.
Okay.
So that could be a factor. I'm going to start using the cream tonight.
Well,
they gave me Premarin cream. Not crazy about that, but That's what they gave me.
Okay, so dryness is real. It happens to all of
Correct.
us. But we can't, it's like the ballerina I was working with on Friday. Okay. Yeah. At first glance, her symptoms started at like the age of 52. It's like, all right, let's go down the estrogen pathway here for a moment. And she was very dry, and it did seem reasonable until she started describing some of her other symptoms like sciatica.
See, I have that too.
So
spinal stenosis. So we're looking at like a conglomerate of things.
Well, but what we're really looking at is cause and effect.
Correct.
We know the effect, frequency, urgency, pressure, pain. Now we got to figure out the cause.
Right.
And if you've got sciatica, you have tight pelvic floor muscles.
Oh, I definitely do, because it
Well-
was helping, but now she's so packed. And they're trying to train other people to do this.
Right.
So
So-
it's just going to take me time, but it's so painful. This is daily.
Do you-
Daily. It doesn't stop, and I'm miserable.
Do you have your wand? Are you using
No, I
your
don't.
wand?
Nobody even told me about that. So when I saw that, I was going to ask you about that also.
So, let me get this here. Where is it? And Kayleen, please, Kayleen, don't leave, because I want to talk to you, girl, because I know your surgery's in a couple of weeks. Okay?
Yeah, I won't be long.
For surgery, but I'll tell you.
Okay. Okay. So anyway, Christy, this is the book I think that is the best for you to understand how your spinal stenosis is affecting everything.
Okay.
This is a master class in pelvic anatomy. And the first 4 chapters are all anatomy. They're just anatomy. They're just teaching you where things are located, right? Because you need to
Okay.
know that. But then as you read this, I want you to be thinking about your injuries. Think about your diagnosis. Think about any other musculoskeletal issues that you have.
Okay.
Because this is where we get context here. This is where, for example, in this book, Dr. Weiss was fascinated by patients whose muscles just stayed tight. No matter what he did, the muscles stayed tight. And they had giant
Yes.
and trigger points. And that's when you take a step back from the muscles and you ask, well, what puts stress on the muscles? Well, number one, weight. Okay. If you remember that your pelvic cavity supports the entire weight of your torso off of your hip bones. And so we have to think about the role of weight on that. That could be playing an issue here. But we also
I've put on some weight.
Yeah, we all have with COVID. So, but the other thing is any bony structure abnormalities or any problems with bones. You've got spinal stenosis, so you clearly have an issue with your spine. But I would want to know if you've got anything going on with your hips or your knee or your feet.
Yeah, I've got 2 bad knees.
Well,
also,
there you go.
so there you go.
There you go. And the way you walk and how you walk is going to be influencing that.
It came on so suddenly. It's amazing.
Yeah. So this is
So what was the book called again?
Breaking Through Chronic Pelvic Pain by Dr. Jerome Weiss.
Okay.
Okay. And you can get these wands. This is easy. The name of the company is IC Relief. We have these in our store. We have 3 different types of them. And I much prefer these over the plastic ones because the plastic ones leave can leave plastic in your body, whereas the last one's
Oh gosh, yeah.
super easy to clean, super
I'm
easy
sorry,
to
my
use.
dog's hurt.
Yeah. So to me, I would be spending more time on understanding your muscles than I would on your bladder, because they've already told you that your bladder looks good. Yes, you're dry. Yes, you're going to need to try to improve the quality and health of your skin, but that doesn't explain why you have spinal stenosis. That doesn't explain why you might have sciatica and the other things. You probably had
I'm sorry. Go ahead.
you probably had muscle problems for years.
Oh, I'm sure. They wanted to do an injection into the bottom of my spine, into the sympathetic nerve to see if it works I'm having rectal pain.
Okay.
And I was just like, no,
Well, I would certainly want to be able to look at the x-rays and maybe even an MRI.
Yeah.
So that they can look at some of those structures there to try to see what's going on. So you've got some detective work to go. But listen, carry hope in your heart here. Here's the deal, is when we can restore good muscle health, some patients are cured. And that was what Dr. Christopher Payne wrote in his subtype proposal years ago, how unfair it was to tell patients they had an incurable bladder disease. Because for many of us, the bladder is a secondary victim of something else. And if
it's so depressing.
Well,
you get really down over it.
But the sky is the limit now. We're no longer stuck in the box of IC. We're no longer stuck in that box of only doing bladder therapies.
Right.
Like patients 30 years ago. Now there are so many more options, so many more doors that we can open to try to understand what's going on. So I say, carry hope in your heart. I've never been more excited than I am right now for the IC world, because we're learning so much now about the other things that can mimic IC. And when we get the correct diagnosis, the patients get better. Okay.
Yes. That's what I'm looking for.
Okay. If you need
thank you, Jill. I'll let you get to the next person.
Okay. And if you need a pep talk, you know who to call. Okay.
Well, thank you so much. I appreciate it.
Okay. Our next person is Jenny. I think it's Jenny. Yeah, I think.
Hi.
Hey, girl. How are you? How
Good.
is life?
I'm not very proficient at Zoom, so.
That's okay. You're doing great.
I'm the one that asked about the intimacy questions.
Yes.
And so I'm so sorry, everybody. It's probably gonna be TMI for everyone, but this is what's gone on with me. So I've been to a urologist. I spoke with her and then saw her, so I'll tell you about that. But my main symptoms always occurred after sex, either with just myself or with my husband.
Okay.
Super TMI.
That's okay.
But they would last about a week or so, a few days or a week, mild UTI type symptoms, always test negative, then would go away. I'd be fine. And this last flare started 2 months ago. And it started, as it always did, like a mild UTI, went in, got tested, it was negative, and then cramping started 3 days later. And it's been like that ever since, menstrual type cramping and really bad urgency. And it started a few weeks ago before my cystoscopy, started to finally feel a little bit better.
Okay.
And sorry again, guys, about the super TMI, but during my sleep, had a dream, woke up with the orgasm, basically the flexing or the contractions or whatever happens when an orgasm happens.
Yeah.
So those contractions, I was like, oh no. So I was finally starting to feel better. So nothing was touched by anyone. And that sent my flare right back through the roof again. And I haven't been that was a few weeks ago. I had my cystoscopy, it was normal. During my physical exam with my urologist, she said that I have tightness on the right side in the pelvic muscles. It was very tender when she pushed up in there.
Yeah. I
have a pouch in my rectum that kind of pushes up into, because I'm having constipation problems as well.
Mm-hmm.
I have this pouch, I forget what she called it, sorry. But it kind of, you can feel it up in the vaginal wall, the bottom of the vaginal wall.
Yeah, I have one too.
Yeah, so I'm having a bunch of constipation problems where it's like I start to go and it's like halfway out and then the muscles just seem to stop working. It just like stuck there. So I end up pushing hard to get it out. So, and this was all happening a year before this bad flare started in April. So,
right.
So I don't know if that sounds, I'm trying D-Manos, I'm trying marshmallow root, tea and pills. I've tried aloe seems to make it worse for me. I'm only taking one pill and it just, every time I take one, the urgency gets worse. So I think it's maybe a bad idea. But I don't know. This is all very, very new to me. I knew I had IC because I was told years ago I had it because of the UTI type symptoms every once in a while. But yeah, that's my story.
So, how old are you?
49. So
And-
I'm perimenopause. Whoa, sorry.
Okay. And when did your symptoms first begin?
In my 20s, I have had a broken tailbone in my 30s, but in my 20s, I had a bad UTI with blood, my first UTI ever. And then that's when the symptoms would start. I'd either get a UTI, usually from condoms with spermicide, would always give me a UTI for some reason. But
Well,
then,
was it always proven a UTI, or did you, or
most of the time, yes, because I don't take antibiotics for no reason. So I make sure I get tested first before I'll start antibiotics. So a lot of the times I would have symptoms. Then I had symptoms without UTI. And then the UTIs became less frequent and it was more just the symptoms. But again, they'd only last a few days or a week and then it'd settle down and I'd go back to life.
Okay.
Food has never really been a trigger except for spicy. If I eat a lot of spicy, which I usually do, I can eat a lot of spicy day after day and be fine. And then sometimes it'll trigger a day or two where it's, a little burning for a day or so. But sex has been my big one. So
the sex pain is pelvic floor pain.
Okay.
That's not bladder pain. That's pelvic floor pain.
Okay.
And what I want to do is read you something. So tell me this. Do you remember when you were in your 20s before this began, do you remember any injuries? Falls, broken tailbone, hurt tailbone?
Broken tailbone happened after, just randomly. I don't even know how I broke it. It just, my tailbone started hurting one day and then they said I was fine, but a year later it was still achy. So they re-x-rayed it and said I had a healed fracture. So, and I had no falls around the time it started hurting. But before the UTI happened, I fell a bunch as a kid. I'm kind of clumsy. So, but, broken bones and stuff, but nothing in my back.
So do you have any other pain besides, have you ever had sciatica, pain shooting down your leg?
No, I haven't had that. I have really bad neck pain. I have chronic neck pain.
Me too.
Cysts everywhere. Basically.
Are you a redhead? You look like you're a redhead.
Yeah, I am. Yeah.
Yay! My redheaded sister.
Very sensitive, very smell sensitive. I get migraines.
Okay. So that puts you. So you and I have central sensitization. So we know that maybe small fiber polyneuropathy is the way. It means that we got super sensitive skin, et cetera, not a disease, and that's the joys of being a redhead. But at some point in time, you suffered a trauma.
Yeah,
and
I've been in a car accident, so that could have, caused it too.
So in this book, Breaking Through Chronic Pelvic Pain, which is the master class of muscle stuff, here's a story. I went to this section on rectal, perineal, tailbone, and orgasmic pain. And
it starts like 2 or 3 days later. Usually, it's not right away. Like when that thing happened with my sleep, I was okay for a while. I'm like, okay, I'm gonna be good. And then that afternoon, it was cramped right back up.
Okay, so let me read this. Lorraine came to me at the age of 46 with a 22-year history of pain in the tailbone and above her pubic bone. She also had pain in her left low back that radiated down the side of her leg and onto her foot, and occasional slowness in starting her stream. Her one relatively minor urinary symptom, which had previously been diagnosed with IC, for which she was treated with DMSO. This inappropriate treatment only intensified her symptoms. When I asked Lorraine about her tailbone injury, she recollected that when she was 12 years old, her cousin pulled her down a flight of stairs on her back, banging her tailbone on each step. Following this event, she experienced tailbone pain for several months. I postulated that even though the initial pain had subsided, the active pelvic muscle trigger points were causing the pain at the time and had merely become asymptomatic, but they had not disappeared. But what could have reactivated them? Lorraine mentioned she'd been under extreme stress and was suffering from back pain and constipation at the time of her tailbone and tailbone and pubic pain began. All of these factors contribute to pelvic floor muscle tightening and trigger point formation. Collectively, they could have certainly tipped the scale and caused latent trigger points around the tailbone to explode into pain. My examination substantiated this preference. She had exquisitely tender trigger points in these muscles. I also found tender trigger points and tight muscles around the puborectalis muscle that related to difficult bowel movements. Additionally, there were trigger points around the urinary sphincter and pubourethralis muscle that explained the slow start of her urinary stream and her orgasmic pain. Okay. When compressed, these points referred pain to the pubic area, the site of her initial complaint. Trigger points in the adductor muscles of the inner thigh and the rectus abdominal muscles of the lower abdomen, as well as tight left piriformis muscles, completed her painful picture. Imagine, Lorraine spent nearly a half of her 46 years seeking relief from pain initiated by a tailbone injury at the age of 12.
Wow.
And so her treatment was internal and external myofascial release and the injection of particularly stubborn trigger points with an anesthetic. This therapy was, let's see, anyway, with the correct treatment, her symptoms resolved.
Okay.
And so, honestly, the fact that your doctor identified tight pelvic floor muscles is a giant clue. When you go to pee, can you start your stream right away, or do you hesitate?
I'll have to pay attention because when you mentioned that, I'm like, I don't know. I'll pay attention. I think it might take a little bit, and I know at the end I feel like I kind of have to push more out. So I'm not sure, but I will pay attention to that next time I go.
I mean, it's so interesting, the role that the pelvic floor plays in all sorts of issues down there, from being able to urinate to being able to have a bowel movement.
Right.
And there's so much complexity and interaction, it's hard to nail it down. But the muscles are a common, constant theme.
Yeah,
and so
my urologist thinks it's probably more pelvic floor. I have PT starting next week for the first time. I've seen her video visit, but I see her for finally a physical visit. It's been a month and a half to get in to see her. But so next week I'll see the pelvic floor therapist. But after the cystoscopy, my urologist said that she thinks it's pelvic floor that's triggering an IC flare. So
well, I'm going to agree with that. I'm going to agree with that. I think that you're my sister. I think you and I, we have sensitive skin. Yeah, we have to live with that. We have a sensitive stomach. We have sensitive sense of smell. That's it's how we're wired, not a disease. And you and I have to take responsibility for protecting our nervous system on a daily basis, which we're already doing because you don't have chemicals in your home. You don't drink caffeine. You're already doing. So that's that.
I'm vegetarian, and I was having a ton of bloating with this as well. So I last week cut out dairy and gluten. I don't know which helped, but the bloating's completely gone in 2 days. It was gone.
See,
so I don't know which one was triggering the bloating.
So. It's the gluten for me that triggers the bloating.
Is it? Okay, I'm hoping it's not the dairy. Although I'd love to be vegan, but I really love cheese.
Well, I'll do it. I don't drink milk. I haven't drunk milk in 30 years, but
I don't either.
But I do coconut milk yogurt, stuff like that. But I bet it's the gluten. I just think that's a common theme. Yeah. All right, hon. Listen, great to talk with you.
So much.
And listen, for everybody in Zoom who's in here, I need you to send me an email address with your mailing address and give me your best flavor. And make sure you put Zoom attendee. I'm writing everybody down because I'm going to send my first giveaways of our new book, IC 101, are going to go to 2 of our Zoom attendees. Okay.
Nice.
So I want to make, I've been writing names down here. I want to make sure I get everybody.
What's the email address? Because when you mentioned it on the Facebook live, I didn't get the app part. So it was IC Network.
IC Network at Mac, like Macintosh computer.
Oh, okay. I emailed someone at math.com. I was like, I think that's what I'm hearing. So they now have my address.
Well, they'll probably delete it. So
Fine. And I'm not worried about it.
Okay. All right, hon.
What chronic pain does for you, stop caring about the little stuff. So
You do. And listen, when you go to physical therapy and they do their first examination, your goal is for them to find the spot that hurts. If it hurts, that is your hallelujah moment. It's like, okay, that's it. What are you touching?
yeah.
What are you touching? So I do not want you to be afraid. Pain is your gift at that appointment. If they can touch it and trigger pain, hallelujah, write it down, find out what it is, and then you go from there on trying to rehabilitate that structure. Okay?
Okay.
Okay.
Thank you so much.
Okay. Nice talking with you.
Nice talking to you. Thank you so much.
All right. So we've got Kayleen and Angel. Angel stepped away. So I'm going to go to Kayleen next. Hey, girl, I have been thinking about you. Can you unmute yourself?
Yeah.
Okay. What the hell happened? What the hell happened?
A lot of things happened.
Okay.
I was just going through a lot, you know. I had lost my cousin, and I'm dealing with that one over there.
Okay.
She's, you know, stressing me out and everything. And then so I had a lot of stomach pain, just a lot of like, you know, bleeding with bowel movements.
Really?
And I'm like, oh my God, like, what do I do? So I'm calling like after hours.
Okay.
And they're like, please go to the ER. You're probably due for a colonoscopy. And
no.
then the ER doctor had said, he's like, yeah, like you're due for, you know, a colonoscopy. It's been 2 years. And then my gastroenterologist, he said that I'm due for a colonoscopy. So he's like, go ahead. And he's like, we're gonna set this up. And which this colonoscopy was in a different setting. I wasn't treated as well. Even though my words got twisted, the words that came out of my mouth got twisted. I mean, I even told my mom, I was like, they're not treating me like really good at all. Like, I'm gonna complain. And I was in like, you know, a 9 out of 10 pain. And I was like, can I just get something to go home with? Like, you know, just something in me that you guys give me right now so I can go to sleep. Like, I know I've had general anesthesia, but like you guys, it wasn't that powerful to like get rid of the pain.
Yeah.
And so that was that, like, and she came in and she's like, well, I'm not going to give you a prescription. And I'm like, well, I'm not asking for a prescription. I'm not that stupid. So anyways, the checkup came up, and mind you, like my neurosurgeon and my GI are in the same region.
Yeah.
Which is, you know, Mercy Health. And I get a call as my GI is walking in the door, and she's like, blah, blah, blah about my surgery. She's like, it's going to be canceled. And I'm like, excuse me, I have to go. I'm like, my doctor is in here. You should know that I'm in my doctor's appointment right now. And she just keeps going on. And I'm like, I have to go. And
so why did they cancel your surgery? I mean, it was so important.
Well, the GI said that, you know, my GI problems are from anxiety and that they need to get under control. He was really nice about it. But I went ahead and I called the neurosurgeon nurse after I got out of the appointment. And I mean, I'm bawling my eyes out. And this is after I told my GI too. I was like, I'm about to like punch a wall right now. Like, I can't believe what she just told me. And but I was telling her, I'm like, I want my life back. I want to be able to like, I mean, because of frequency and urgency, like it is the nerves that go to anything pelvic. So uterus, bladder, ovaries, anything.
Vulva. Yeah.
Yeah, definitely vulva. Oh my God, I could feel it. And I mean, I have vulvodynia, and like nobody's helping me with that. Well, that's a doctor from a totally other region, which I can't stand. I don't like them.
So, but why did they cancel your surgery?
Supposedly it's because of my age. I mean, I'm 26. That, and then I think, I mean, I'm not sure if it's because everything that I've been going through or what.
Well, let's refresh our memory. What was the surgery going to be? Was it going to tell us it's going to be on the 28th of this month because I put you on my calendar.
Yeah, it was for because I have spinal stenosis and L4 and L5.
Okay.
And degenerative disc disease.
Okay.
But it said like possible discectomy, like, and I'm like, why is it possible? Like when the surgery was scheduled and, you know, it was on my chart and everything. I'm like, why is it like possible discectomy? But yeah, something about he would have put a rod in between L4 and L5.
Okay.
And then, I don't know, stuck something in it, like a speculum type thing.
Yeah.
And then he would have like, I don't know. But yeah, I was like bawling my eyes out, you know, just getting out of the hospital after seeing the doctor. And I'm just bawling my eyes out and I'm telling her like, I want my life back. Like I literally cannot do anything to my cats. I can't feed them. I can't do the litter box. I can't
well, yeah,
I can't fill up their water bowl. Like I'm literally lifeless. Like I am living in my bed. I can't even sit in this chair. And this chair is
yeah.
It's a lumbar. It's got massage and everything. And
so did they
sit in my couch
are they going to reschedule it?
They said nothing right now.
Okay.
And they said to stop contacting them. Like I can't even message him on my chart. So I don't know what to do. And I got to the point where I was like, or I called up my urogynecologist and I'm like, hey, I'm having a lot of endometriosis pain. I'm like, I'm having a lot of urinary pain. And I think it's because everything is pressing up against my bladder or my urethra or my vulva. And I'm like, you guys didn't even talk to me much about my vulvodynia. And that's the main reason why I came here. I just went to you because I know that you're a surgeon. You know, you specialize in endometriosis also. And so I called them and I'm like, you guys aren't going to do anything, then I'm done. And even got a second opinion, but that was months ago.
Okay. So listen, it's time to do a reset here, Kayleen. It is time to do a reset. You have every right to be angry. You have every right to be frustrated. You have every right to want to scream at anybody who has not helped you. You have that right to do it, but it's not going to get you anywhere. It's just not going to get you anywhere. What's going to get you somewhere is, you know, you've got to separate cause and effect in your brain and your discussion. There's a cause that's causing symptoms. You're having vulvodynia, you're having spinal pain, you're having uterine pain, you're having vaginal pain, you're having pain. And when you're talking with them, what you have to make clear to them is you want to fix the cause. I am here not for pain medicine. I am here not for trivial stuff. I am here to try to figure out why I have this pain. We have two huge clues. We know that there's an issue with my spinal cord, and we know that there's an issue with endometriosis. Two separate but potentially connected condition. And I suspect, and listen, girl, you are my sister. And so I'm just going to be as honest to you as I would be to my sister. You have to be very, I want to say, deceptively focused when you work with your doctors. You can't get lost in the little things, even though they're big.
Vulnerable.
You can't get lost in the you've done nothing for my vulvodynia or anything at all like that. Well, you have to be tunnel vision. I want to know what's wrong with my spine. I want to know if I have endometriosis. It's that easy. I want to know I want to know if these are dominant problems for me. And I suspect that you got pretty wound up and you just let it fly.
Well, I did admit to them. I was like, to my GI, I'm like, hey, you've been really nice to me. I've been like an emotional wreck and everything. And I understand, that the brain and anxiety, anxiety and GI is all connected.
Oh, yeah.
And I'm like, but everyone else are being dicks. So I'm going to go ahead and just give up. Like, I admit, I'm going to give you guys what you want. So I went ahead and I checked myself into the psychiatric ward.
Okay.
I was in there for 5 days.
Okay.
So, here, I got my bracelet here, and I got, I made a few rocks when I was in there. Oh, it's reversed, but okay, now it's right.
Okay. And what did you gain from that experience?
I mean, it has helped a lot.
Oh, good.
I'm not like tossing and turning at night anymore. Like, it's like I needed that break from my bed.
Yeah.
Even though I missed my cats, oh my God. Couldn't have my phone. So that was a kind of a nice break, but I did miss my music. I had a TV. There was only one other patient. I had my own bathroom. That patient had their own bathroom. I mean, we were constantly watched, but like those nurses were just like everything. And I had a really ugly UTI while I was in there. It was from the bladder insulation.
Okay.
But I had the bladder insulation on the Friday before I went in there. That Sunday, I was like, hey, like, I called up my urologist and I was like, I'm going, and like the stream is like perfectly fine, but once it gets to the end, it's like everything is just like pins and needles, and it goes.
Yeah, it's a bladder.
It hurts so bad.
It's a bladder spasm. That's how bladder spasms present. Is that the last couple of drops come out, everything goes. It's just
Yeah.
And you bend over on the toilet and go, oh my God, what is this?
It's just I didn't even want to like drink water. I went into the hospital where my urogynecologist was, and they had checked me. They said that even though I can't find any proof where it says that, but that my white blood cell count was 33%. And I told the hospital that, like, there was a doctor that came in to check to make sure that I should be in the mental hospital, not the hospital. And she was saying, she's like, that's like hospital. She's like, here's a urinalysis. So I'm like, you're giving me a urinalysis while on Bactrim? But the thing with that, which I still have, is the stream just hurts coming out. I mean, it's like I'm holding on to both sides, and I'm like,
Yeah. Well, that's common with UTI, but that's also common with estrogen atrophy. So,
So am I low on estrogen then?
You could be. You could.
That's not good.
Well, we don't know. I mean, I'm guessing, and you deserve much better than a guess. We need some facts here. I think that you had a nice breakaway. Listen, in 3 years, I haven't had a vacation in 3 years caring for my parents. And let me tell you, exhaustion at times. Some days it hits hard. It hit hard last night. So just being able to have a little break away is just like, so God, please just let me get a break here for a
Yes.
moment. So you've had that break, time to reset. And I need you to make your list of the things we're trying to work on. So we're trying to work on number one, what's going on with your muscles. Number two, what's going on with the endo. Number three, what's going on with your spine. And number four, being so incredibly grounded in the anxiety, because anxiety amps everything
Yes.
up. And are you doing your stop sign, deep breath thing that we talk about all the time?
Yeah.
Kaylee?
I told him about tapping, actually. I told him about you, and I was like, this is she told me about tapping. It's what PTSD sufferers deal with. But they were doing this, and I'm like, I don't like it. I like tapping a lot better.
Yeah. Okay,
it
but
was that, and then
stop sign, deep breath, minimize the thought. Are you doing that?
Yeah, like coping mechanisms.
No. You're deflecting. You're deflecting. Okay. Every time you have a negative thought, and girl, I know you because I know me, you have a lot of negative thoughts, right? Although,
yeah, I got a lot of problems.
well, I know, but we all had a lot of problems. But a lot of it comes from just the fact that we're living in fight or flight. That's all. We've been traumatized. We're living in fight or flight. So every time you have a negative thought, you have to, number one, visualize the stop sign. Just close your brain for a moment and just focus, like stop sign. Just stop your brain for a moment. Then you take a nice, slow, deep breath in for 3 and out for 3. And that one breath renders the adrenaline from the negative thought chemically neutral. Because right now you are an adrenaline overload. And you have a lot of negative thoughts. You got a lot of jolts of adrenaline going through your body. And it's the equivalent of a chemical sensitivity. So what my anxiety class taught me, and was developed by a surgeon with anxiety, is every time you have a negative thought, visualize the stop sign. Just stop your brain for a moment. Just stop. One deep breath in, out. And then you just have to remind yourself, you have to remind yourself it's a thought. It has no power. And so what I say to myself is, oh my God, Jill, you're not God. You can't predict the future. For all you know, tomorrow's going to be a great day. Right?
Right.
So what the goal of the anxiety management class that I was in, which completely changed my life, I have never had a panic attack since, even going through uterine cancer scare, was to keep adrenaline as low as possible. Stop sign, deep breath, minimize the thought. They sent us home and they said, be attentive. We have one goal for this week, get your adrenaline levels down. So you're going to do this at least 100 times in the next 24 hours. So we just need you to be really attentive to your negative thoughts. And when I did, I was shocked that like every thought I had was negative. It's like, nobody will help me. This won't work. That won't work. No, I don't want to go to a movie. It'll hurt. No, I don't want to take a drive. It'll hurt. No, I don't want to do this. No, I don't want to do that. Okay. And every time you have that thought, you give yourself a jolt of adrenaline. So they were right. I did it like 100 times the first day. The next day I did it like 50 times. The next day I did it like 20 times. By the end of the week, once. And for the first time in a decade, I was calm.
Wow. I know adrenaline really affects the kidneys, and that's definitely what hurt when I had the UTI. And I knew how I got the UTI. I'm like, I'm not gonna blame my urologist and be like, oh, you're such a horrible doctor. You gave me a UTI from a bladder installation. No, it happens. It's not his fault. It's not my fault.
Right. There's no shame. There's no blame, and there's no fault. It happens. You have a body. You know?
Right. Something from outside is going in that's not supposed to be in. But I do this bladder installation thing. It's supposed to be after my period, so once a month. But I've been getting my periods like 3 times a month. So going to my OBGYN, and because I just told him, I'm like urinary wise and just vaginally, like having a period hurts.
Yeah.
And so I'm going from the pill, which is low estrogen, So you're supposed to have like 2 or 3 days of periods, which I was having 8, 9, 10 days, and then another like 5 to 7 days. So 2 periods in the same month. It was just too much for me. So they're gonna put the ring in, but they're gonna do it instead of me just doing it. I've never done tampons. My mom has never done tampons. My grandma has never done tampons. I don't want to learn. I don't.
Well, I mean, listen, it's your body. You're in control. You get to decide what you want to do or not want to do. What I feel, what I'm getting from you is that you're kind of like a bouncing ball bouncing off the walls, kind of sort of between all of your symptoms. It's like you've got this, and you got like this, and you got this, and you got this, and you're just like it's like you're just bouncing all over the place. And my suggestion to you would be to, number one, step back, deep breath. Let's get some calmness in here, because nobody can do that but you and me. We have to take responsibility for that. And that stop sign, deep breath, tapping, whatever, it all works. No shame, no blame, it works. We're just trying to calm the sympathetic nervous system down. And then let's just you have to be more focused with your doctors, in my opinion. Try to get them to focus on what you need them to focus on. Like, why does it hurt when you have a period? Why does it hurt here? And rather than getting into the anger and all that other stuff that you legitimately have, nobody's saying that's wrong. We just don't, you just, write it down in a journal so it doesn't dominate your appointments. It shouldn't be in your appointments at all. It's like, I'm here because I'm trying to understand what could be causing this, and just try not to let that interfere. You have every right to be angry, but it will only get in the way, if that makes sense.
Yeah, it's I have a primary doctor's appointment coming up. It was supposed to be my pre-op.
Well,
no, that's not happening.
Well, just use it as a new opportunity. And oh, I just lost Angel, darn it. I just want you to be more steadfast, more determined, and yet very calm. And I think one of the barriers that you have, that so many younger patients have, is that you're just younger. And sometimes they just don't believe younger people.
Right. That's the issue I'm having with Social Security. I cannot work. I would love to work. Can you?
It's okay.
I just don't know if she's gonna go to the bathroom with the door open.
It's okay.
Because I was gonna say I'm on Zoom. But I have been trying to tell my doctors, like, hey, like, I'm not trying to waste anyone's time. I don't even have my own time to waste, but just please, like, help me. That's all I want. Like, you guys are the doctor. I'm not. Like, I know what's going on with my body. Here's the pain. Here's the pain. Things like that. And it's.
Yeah, I know. I know, hon.
All right. I'm asking for, but I'll let you go.
Good luck with that next appointment. And Angel, if you're watching, I was just coming to you, hon. Angel, please feel free to call me this week. I would love to talk with you. I'm so sorry that we couldn't get to you in time. All right. All right, everybody. Well, listen, our Zoom meeting is over unless Angel wants to come back in. I'll leave that open just a little bit. And let's come back to Facebook and YouTube. Let's see here. Pauline says, will IC101 be available on Amazon? Yes, it will be as soon as I can get it there. I've been doing just a massive amount of work with it. So let me go back here. So now we're back on Facebook and back on YouTube. Christy says, I have no estrogen. They want me to use Premarin twice a week. Premarin is a little bit challenging, has a lot of extra chemicals in it that can be irritating. And so we tend to do better with a compounded chemical-free formula than with Premarin, but worth a shot. Just if it burns a lot, it's probably just from the preservatives in it. Yvette says, don't forget to take progesterone with estrogen if you have a uterus. Absolutely. Rhonda's encouraging the compounding pharmacy. Yeah, you know, the other thing that's so interesting is Premarin, and they pay for big TV campaigns, you know, about painful sex and how this can help with painful sex. It's ironic that it's the most expensive thing out there, and it could cost $200 a prescription, whereas a compounded estrogen cream might cost $40 for a 3-month supply. So there are, between the industry of keeping horses pregnant, combined with the cost, combined with the chemicals, it's just not usually suggested. Somebody's asking about alkaline water. Alkaline water is just where the pH is increased to make it more alkaline. And that's usually they would add something to it, like sodium bicarbonate or potassium citrate, something like that. Pauline says, my physiotherapist told me I have a prolapse. Yeah, it happens. Pauline says, could a damaged tailbone cause low back pain on one side? Absolutely, 100%. 100%. A damaged tailbone is the foundation for issues. It's stunning what we've learned now about what tailbone injuries can do to the bladder and cause bladder symptoms. Absolutely stunning. All righty. So I want to read my introduction. So again, for this meeting, this is our new book, IC 101. It's not just a bladder disease. Just released this week. Super, super excited about it. I'm going to give away a couple of copies. So for those of you who might be interested in getting a free copy of IC 101, you need to email me, icnetwork@mac.com, icnetwork@mac.com. That's M as in Mary, A as in Apple, C as in Charlie. So I'm going to read my introduction. The dream of every patient diagnosed with IC is to find a cure. We want a treatment that will eliminate our bladder symptoms and pain, allow us to eat foods or drinks again that we've avoided for years, work comfortably, and of course, enjoy intimacy again. And if you've had IC for more than a year, the odds are that you've tried a variety of treatments such as oral medications, bladder installations, OTC supplements, neuromodulation, or perhaps even Botox or cyclosporin. Yet despite this wide variety of interventions, many of you are still struggling to find relief. As much as we would like to have one treatment that would heal most patients, it simply isn't available. And there's an important reason why. Visit any IC support group or online support forum, and you'll quickly see that not all patients are the same. Some have agonizing Hunner's lesions on their bladder wall, while others have a normal, healthy bladder, myself included. Some patients struggle with mild frequency and urgency, while others have intense pain. Some also struggle with other chronic pain conditions such as IBS, vulvodynia, fibromyalgia, migraines, TMJ, etc., while others only have bladder symptoms. And despite their common diagnosis of interstitial cystitis, clearly these patients are not the same. You can see even more diversity in the events which trigger the onset of IC symptoms. Many women report that their symptoms began after delivering a baby, while men often report that their symptoms began after riding motorcycles or bicycles. A history of athletics or pelvic traumas, repetitive falls, or tailbone injuries are common in both sexes. There's a cluster of men and women whose symptoms appear to begin after an infection, while it might be a simple UTI, an STD, or even Lyme disease. Exposure to harsh chemicals such as chemotherapy, ketamine, or the excessive consumption of coffee or soda is a common cause of bladder irritation. Aging, hormones, and genetics can also play a role. Thus, given the myriad of ways that ICBPS manifests in different patients, as well as the diversity of events that appear to trigger its onset, it's no surprise that a one-treatment-fits-all approach, much less a one-cure-fits-all approach, does not work. But there is hope. Recent advances in the phenotyping of IC have revolutionized the care of patients around the world. Patients in Europe are given the most aggressive diagnostic workup requiring hydrodistension. Based upon their symptoms and biopsy results, they are then classified into one of 12 different subtypes of bladder pain. The Canadian Urology Association encourages the use of a 6-point system known as U-point. The American Urology Association has not yet recommended a specific system, though several are being studied. I use a system developed by Dr. Christopher Payne, former director of female urology at Stanford University. In his proposal, Dr. Payne complained that a diagnosis of IC left both the patient and the clinician unsure of what treatments to pursue. He suggested that if the diagnosis was more specific and individualized, a clearer, more effective treatment pathway would emerge. Dr. Payne proposed 5 fundamental subtypes: Hunner's lesions, bladder wall driven, pelvic floor driven, pudendal neuralgia, and central sensitization, each with their own treatment priorities. Within each category, some additional variants are recognized, such as the genitourinary syndrome of menopause or chronic infection in IC subtype 2 bladder wall driven. And he also suggests that more variants could be identified in the future. The Payne phenotyping system encourages a more thorough diagnostic workup, more effective treatment planning, and provides better insight into the prevention and treatment of IC flares. It has played a significant role in my life and how I work with my clients in the IC Network office. So understanding my subtype. So this is my subtype. Central sensitization primary. Using Dr. Payne's system, my primary subtype is central sensitization. As a child, I have had very sensitive skin and could not tolerate bubble baths or wearing clothing that contained wool or had rough textures. My stomach began to rebel in elementary school. In junior high, my bladder became sensitive, and I often couldn't sit through an hour-long class without using the restroom. I began to develop vulvodynia in high school, which had my gynecologist claiming that I had the most sensitive skin he had ever worked with. Irritable bowel symptoms hit in my early 20s, along with some new food sensitivities to oatmeal and chocolate. I began noticing more intense smells and tastes. Harsh chemicals such as oven cleaners, turpentine, wood solvents, and petroleum had me running out of rooms or buildings because they hurt. I experienced sporadic migraines and TMJ. And at the age of 32, bladder symptoms hit so severely that I couldn't sleep or drive without severe pain and discomfort. My anxiety levels were off the charts. 3 key breakthroughs helped me make sense of my chaotic body. Researchers at the University of Maryland found that IC could run in families. And that was interesting because my sister, my mother, aunt, cousin, and grandmother each struggled with bladder symptoms and very sensitive skin. Then researchers started floating the concept of central sensitization in patients with bladder symptoms who appeared to have normal bladder, healthy bladder walls. They believed that the nervous system was the root of bladder symptoms. And one of the classic signs of central sensitization is a very sensitive sense of smell and sensitive skin. I came to realize that almost every medical condition that I've struggled with could be attributed to a sensitive nervous system and, more importantly, my genetics. It was never my fault. We also understand what is driving some of this sensitivity. Small fiber polyneuropathy is found in 60% of patients with chronic overlapping pain conditions. The smallest in diameter nerves in the body have been injured. Neuropathies are associated with several illnesses such as diabetes, Lyme disease, shingles, and other viral conditions. Vitamin B12 deficiency is a well-known cause and fits nicely into one theory that some patients may have inherited a vitamin B12 deficiency disorder. Nerves can be damaged due to an excess of B6, heavy metal exposure, organophosphates, and sadly, some of the antibiotics that were often given years ago to patients with suspected UTI. But I have another complicating factor. I'm a redhead, and it is well known that redheads struggle with more pain sensitivity. I can personally attest to the fact that it takes more anesthesia to numb us for dental work. Red hair occurs when both parents carry a mutation of the MC1R gene, which also surprisingly affects pain processing in the brain. Redheads are more sensitive to certain kind of pain. We often require more anesthesia for surgical procedures. And yes, we aren't being dramatic. Research studies have proven that our nervous system is different. I don't view central sensitization as a disease, but rather the landscape of my body. I am hardwired to be more sensitive, and it is my responsibility to calm and soothe my nervous system through diet, stress management, and various treatments. I respect the fact that my bladder, my stomach, and my bowel are easily irritated by certain foods. I choose not to drink caffeine because it overstimulates my nervous system. I know that when I'm under stress, my body is more reactive. I take the time to rest, relax, and practice good stress management skills. And I am remarkably healthier today at the age of 60 than I was 25 years ago. My second and more painful subtype is pelvic floor driven. The year that my bladder symptoms began, I had broken my tailbone and developed mild scoliosis. Because I was unable to sit through class, the teachers complained, and I was eventually seen by a urologist who diagnosed me with a urethral stricture, a narrowing of the urethra. Back in the 1970s, they forced the urethra open with a metal rod, and yes, it is as awful as it sounds. I had dozens of these dilations over the next few years, but in hindsight, I wonder why nobody asked, why is her urethra narrow? I believe that my pelvic floor muscles, specifically the group of muscles known as the levator ani, were tight to compensate for my tailbone injury. Hindsight has also helped me to see that what I thought were bladder flares in my 30s were usually pelvic floor spasms. I was startled badly one day and felt like I was going to leak urine. For several hours, I deliberately clenched my pelvic floor muscles until I returned home. The result was a wicked, days-long flare of frequency urgency pain. This proved to me that muscles could trigger the symptoms I had associated with the bladder for decades. And not surprisingly, pelvic floor physical therapy was far more successful at reducing my symptoms than years of bladder treatments. Patients who contact my office are often surprised when I say we no longer consider IC an incurable bladder disease. Rather, we think of it as a pelvic pain syndrome. Why? Because other structures in the pelvis are often involved. Now we know why bladder therapies don't work for so many. And as Dr. Payne wrote, some patients are indeed curable if they are given the correct treatment, especially those with pelvic floor dysfunction. But we can't talk about effective treatments until we understand your anatomy. Are your muscles tight? Does your bladder wall have lesions? Are you suffering with any nerve-driven symptoms like sciatica, pins and needles, or PGAD? Does anyone else in your family share some of your symptoms? Do you have other painful conditions? The purpose of this book is to help you, the newly diagnosed or veteran patient, understand more about your unique case of IC and to help you focus on the most effective self-help strategies. You can't find more qualified authors than Gay and Andrew Sandler. In their first two books, Patient to Patient, Managing IC-Related Conditions and The Proactive Patient, they offered a veritable Bible of self-help strategies that have helped thousands of patients get through the day. They cover a diverse, important range of topics from managing diet and exploring treatments to the impact of hormones and aging on the bladder. A muscle and movement re-education practitioner, Gay shares exercises on how to relax the pelvic floor. Andrew offers insight as the husband of an IC patient, and together they provide a toolkit to help couples maintain intimacy in their relationships. It has been a privilege to contribute to the second edition of this book and to introduce Dr. Payne's work. While there will and undoubtedly be more phenotypes or subtypes proposed in the coming years, we finally have a system that makes sense of the chaos of life with IC. We can now more accurately diagnose patients and focus on more effective treatments. There is hope for patients with IC. You are not alone. You did not cause your IC. It is not your fault, nor are you damaged goods. Your IC could be the result of an injury or trauma to your pelvis rather than a disease process. And your job is to create an environment that will support healing of your bladder wall, your pelvic floor, and your nervous system. Gay Andrew and I offer many tips that will help you through your journey with IC. And of course, if you would like to talk with someone and or read more, please come visit our website, the IC Network. We welcome you. So that is the introduction that I wrote for this book, IC 101. You can get this on our website at icnetwork.com. It will be on Amazon, hopefully this week. And I really, really, really hope that it helps. This is a 2-year process. So a lot of you have been wondering where have I been, especially in the last 6 months? Why haven't I done more drop-in support group meetings? It's because of this baby. Man, this has been a beast of a job to do, but I really, truly hope that it helps. I think it will. I believe that it will. So, all right, guys. Well, listen, we've been going for 3 hours. I think it's time to end this. I'm going to give you your homework. Your homework is for 15 minutes a day. I need you to do something for your spirit. Come on, let's get some peace going in your body and in your brain, whether it is attending a church service, reading poetry, sitting out in the sun, talking with a friend. Do it. For 15 minutes a day, I need you to do something for your bladder, your pelvic floor. Come on, get down on the freaking floor and do your exercises. For 15 minutes a day, I need you to do something to learn more. Read a chapter in the book. Come to our website. Read our blog. Let's get your knowledge level up here. You know, it's stunning. The number of patients who were diagnosed 20, 30, 40 years ago, they've never read anything about it. And their minds are blown when I share with them the new information. And then last but not least, I need you to do something that will help you laugh. We need laughter. When you are laughing, your brain minimizes pain. When you are crying and anxious, your brain intensifies pain. We need to get some laughter back in your daily life. So please, please, please do something fun, whether it's watching funny videos, reading a funny book, talking with a friend. Let's get some laughter in your daily life, okay? Open the windows, get out of your bedroom, open the windows, let the sun shine in. Why? And if you're having trouble walking, just do little bits every day. Nobody's looking for something big. Little steps every day will build a good foundation of healing and of success for you, my friends. All right. Okay. I'm going to call it here. Peace to everyone. Okay. So this is the heart. This is the new way of saying, love. So love to everybody. And I will be back. And I think I'll be doing a drop-in meeting this week for sure, now that I'm done with the beast. All right, you guys, I'll talk to you later. Have a good